more time, you can hear me?
Yep, can hear you.
It works this way. Otherwise, I'll call back in. Getting feedback, Michelle.
Yeah, and you're kind of choppy, Michael. You're only like every other word.
Michelle, I'm going to call back in. Go ahead with the attendance.
The welcome.
And I'll come back in for the welcome real quick.
All right, thanks everyone for joining us for this special meeting this morning. Just a reminder, this is a 3-hour-long meeting, so we'll end at noon rather than 11. And wanted to just give a real brief welcome and overview of the meeting agenda and the objectives that we have for today. We're going to skip over certain things like roll call for the sake of time, so we can make the most of this time together. And in terms of how the agenda was put together and the objectives that we have, in the past several SURSAC meetings on this topic, the criminal legal response, if any, to possession of controlled substances, a few themes have been coming up, and we wanted to, upon request, create some time to speak with and hear from subject matter experts to learn a bit more about the nuances and different elements of this kind of policy creation and implications around those different policy options. So we are hearing from Mark Cook, who's an expert in possession and drug policy from ACLU. We're also hearing from the Washington Lead Technical Assistance Team to learn more about diversion strategies being used in Washington State. Adam Paliu from the University of Washington is here to talk about different safe supply models. Tara Hurst, who was involved in Measure 110 in Oregon State, is here to talk about their experience in decriminalization. And then Deontay Damper from Vocal Washington is here to discuss disparities and inequity in criminal legal responses to possession. And I know that that's not a comprehensive list of all the things that we could and want to talk about, but just given the time constraints and the urgency of getting to a recommendation for the plan, it's what we have for you. And I'm actually very excited to hear from all of these folks and look forward to the conversation that we'll have near the end of the meeting. So if you take a look at the agenda, we've got presentations, 10 to 15 minutes each, followed by 10 minutes of Q&A. And then around 11:10, for the final 50 minutes or so of the meeting, we will be working on coming to, I want to say some consensus, but really just building out the top polled options that we arrived at from the last SURSAC meeting. So taking what we're learning from the presentations from these subject matter experts and strengthening those options as much as possible so that on Monday, when we do the final vote to see what recommendation the committee wants to present for the plan, they're as strong as possible, whether, for the decriminalization, legalization, misdemeanor, whatever we really want to focus on and land on, that those are as strong as they possibly can be. And in the meantime, if there's ideas that come up with these presentations that subcommittees want to pursue, those are also all options. But the primary objective of today's meeting is to really come to some solid recommendations around possession of controlled substances. So with that said, I will hand it over to Michael for agenda item number 2.
Okay, thank you. Michelle, can you hear me now? Please say yes. Okay, thank you. I was getting a little stressed there for a moment. So I trust that you've done the attendance, and I heard you here at the end go through some of the expectations for today. So really what I want to do is welcome you all here. This is a special meeting. It's a meeting that you asked for in order to go a little deeper into conversations related to possession and some of our options before we vote on Monday. And I think Michelle just went through that with you. So for those guests that are here today, thank you. Thank you for coming and sharing what you know about the topics that we're going to cover. For members, thank you for giving another 3 hours of your time to this process. We really appreciate it. I think it's going to do us well as we try to get to final recommendations on Monday. So in terms of time, I'd rather just jump in now because even with 3 hours, I think we have so much content and opportunity for discussion to sort of add to the remarks and our thinking around the options that I don't want to cut that short. So again, if I haven't met you, I'm Michael Langer. I'm Deputy Director with the Division of Behavioral Health and Recovery and the Chair of the SURSAC Committee. So thank you all for being here. And I will, and also should note that Blake Ellison is here. He will help facilitate and along with Michelle. And when we get to the point of taking notes later in the meeting, we will do that so you can see the notes that we're taking for all transparency. Also, if Michelle didn't mention, the options were sent out. And so you have those as a guide throughout the conversation this morning so that you can kind of take your own notes as you're hearing comments come in from the presenters. So with that, Michelle, I believe we're at the point of turning this over to Mark, unless you tell me there's something else we need to do before then.
I think we're all set to have Mark begin his presentation.
All right, Mark, welcome. It's good to see you again. Look forward to hearing what you have to say. So thank you for joining us today.
Thank you, Michael. Thank you, Michelle. Can you all hear me okay? It's coming through clear? Great. All right, I'm going to try to share my screen for just these brief PowerPoint slides. Hang on 1 second. That pop up okay? Oh. Tell me if you're seeing this.
We can see it.
Yes.
Yes.
Looks good.
Okay. Great. Thank you so much. And before I get started, apologies if there is background noise here. My home has become a de facto child care center while we are dealing with some school strike issues in my home. So apologies if there's some background noise. But thank you again for having me so much. My name is Mark Cook, he, him pronouns. I am with the ACLU of Washington. I'm a policy attorney there. I've been working on drug policy and criminal, legal, and behavioral health issues there since 2008. I also, before I get into my brief comments, want to just say thanks to all of you and people who frankly are directly impacted by substance use disorders and have been, trying to change, I think, really unfair and ineffective laws for many decades. And I'm just very mindful of my place of privilege being in a situation like this. And I want to always have us being focused on people directly impacted by these systems and these laws as we talk about it. Also, just want to quickly mention my long-term colleague, Allison Holcomb, is on the call. And if there are any questions after the brief slides, I'm hoping she'd be willing to share her thoughts as well. And then finally, just before I jump into content, really huge thanks to everybody involved with the SURSAC committee. It's a huge amount of work. It's a big time commitment, much of it not compensated. And really just appreciate everybody sticking with it, even if there are disagreements and challenges. It's really important work for Washington State, and I hope that it leads to some really good outcomes. Okay, jumping into kind of thoughts and why is the ACLU of Washington here? We have been working for many decades at this point on trying to reform systems so that we treat substance use disorder as a public health issue and not a criminal justice one. And our belief is that public health responses will have better outcomes than punitive ones, but just want to be really upfront that we're certainly not a neutral party here, and that we are very much focused on trying to reform laws. And I think that's why we were asked to be here, is we've done some very concrete work with many others, many who are on this call, to try to actually make these laws permanent in Washington State. And also just want to be upfront that, we really believe that the war on drugs comes from a racist background. And if you look at how it has been enforced and who it has impacted, really is important to always point out. Wealthy, privileged white people, in my opinion, have largely had decriminalized drugs for many decades at this point. If you could, have a drug dealer come to your home and use in that safe environment, you really haven't had to worry about criminal legal complications. So just wanted to be very upfront with our first comment there that, you know, we are trying to reform these laws in a public health oriented way. And just always want to note the stigma that surrounds these topics. And I think one of the fundamental beliefs we have in that why we think, you know, possession should not be a criminal issue is the stigma that comes around it. And if you have a medical condition that every time, you know, you are using a substance because of that condition and are a criminal because of it, that there is just incredible stigma that comes from that. And we think there would be better outcomes if, you know, people had help instead of, you know, being viewed as punishment. The next comment is just that Washington undoubtedly is having troubles with drug policy and with substance use. But it's, I think, unfair to say that it is because of, you know, the Blake decision or 5476 that is causing that. So, you know, there's lots of statistics out there, but I wanted to just highlight one where between, you know, March 2021 and March 2022, just the huge increases in drug overdoses across the country are massive, right? And I think the evidence is becoming more and more clear that much of that is being driven by things such as the pandemic and the workforce issues that we are facing in the behavioral health context, and just frankly, the lack of services that are out there. Not to minimize that Washington is really struggling, but I think it's a really disingenuous thing to say that solely because of these recent law changes, that's why things are happening in Washington state, when the reality is the entire country are struggling with similar issues. The next point that I think we wanted to make is that it's important to remember that major changes to drug laws do happen, and they really can have beneficial outcomes. And I think there's a real risk that we sort of, you know, revert to the status quo as being, you know, something that it's always going to be there. And I don't think that's the case. You know, Washington State has the great honor of having the first, you know, legally sanctioned needle exchange program from Tacoma and the Dave Purchase Project, you know, going back several decades. We were also one of the first states to pass a death with dignity law, right? Even though the federal government at that time was very much opposed to that type of policy. And then more recently, you know, we have marijuana legalization in Washington State, an initiative 502 from 2012, you know, which ACLU of Washington was very involved with. And it certainly wasn't perfect. You know, lots of issues with it. Probably most notably, it was not successful in creating an equitable marketplace for people that were most negatively impacted by the war on drugs, being able to access, you know, this new marketplace. But I think at the same time, there was a parade of horribles, you know, people would roll out about marijuana legalization before, you know, literally half the country has now done it. And I think that in large part, it's been fairly successful, right, in terms of creating a non-punitive system instead of what was happening previously, where it was, you know, many people were being arrested for low-level marijuana offenses, and they no longer are. And I think that was a success that we've had less harm from marijuana prohibition. The next comment I wanted to make is, sorry, there's some background if people can mute if possible. In terms of drug possession specifically, and different approaches to that, community advocates in Washington have been working on that issue explicitly for many years at this point, going back to Initiative 1715 in 2020. At the same time, Oregon was decriminalizing. I think we would have passed that law, frankly, but the pandemic prevented it from getting on the ballot. Then we went to House Bill 1499, the Pathways to Recovery Act, prime sponsored by Representative Davis, which I think was frankly groundbreaking legislation, and it brought people together, many advocates, and often we disagreed with each other about, you know, this specific policy or that specific policy, but we were all committed to trying different things. And I think House Bill 1499 was a better policy than Initiative 715 because of those disagreements and because of that collaboration. And I think the SURSAC committee should learn from those lessons. I think you really should be listening to directly impacted people, to community service providers in terms of making recommendations. So really grateful that we're all here today talking about those issues. And then the last, kind of point on that front is Initiative 1922, which was run by the Commit to Change Washington campaign. Sadly, we weren't able to get this on the ballot this year. I think, frankly, again, just due to pandemic issues and workforce issues for signature gathering and things like that. Also want to acknowledge Julian Saucier, who was on the SURSAC committee, but was also a steering committee member for Commit to Change Washington. And I-1922, again, I think was even an improvement over House Bill 1499 in terms of its policy focus, which I'll talk about in a minute, and that really just kind of continuing to refine and to work through, tricky policy questions. And I think that is a major point I wanted to get across to you all today, is that no matter what, any policy change, it's going to take years to really figure out and to work through. And I hear frequently, oh, we've tried decriminalization in Washington now because of Blake, because of 5476. We need to go back to the old way. And I think that would be a grave, grave mistake. The kind of previous drug possession law in Washington state was passed in 1971, the Uniform Controlled Substances Act. And we had 50 years of primarily dealing with that issue as a criminal response. And my belief is that it was not effective, and we should be trying something different. And yes, 5476 recovery navigator programs, they're just getting rolled out, and they're getting rolled out in the midst of a global pandemic. We need more time to try different approaches. And I really hope that sticks with you all, that it's going to take time, and we're not going to fix things overnight. And it would be a real mistake to sort of run back to what may feel more comfortable to many, even though we know that hasn't worked over the years either. Some specific policy considerations. I think the SURSAC recommendation, right? You have to recommendations regarding the appropriate legal system response, if any, to possession of a controlled substance. I think that is a very broad mandate. And there's kind of this initial question you should all be thinking about. Do you need sort of a broad statement that's sort of ideological in nature, or do you get into really nitty-gritty policy details? And I don't have the answer to that, but I would note that the policy details get very tricky very quickly. And, you could go down various paths, right? So there is technical decriminalization, which means that, possessing something is no longer a crime in Washington. It could still be a civil offense. It could be nothing at all. It could be a referral. You can have depenalization, which is sort of what 5476 did, where it's no longer a felony, but it's now a misdemeanor with diversion options. Or you could keep it a crime, but say, yeah, we have to divert. And I think diversion, just want to note, and I'm so glad you'll get to hear from my great friends with the LEAD program, that no matter what you do with the technical, action of possessing a drug, diversion and the criminal legal system are going to be a part no matter what, right? Nobody's talking about decriminalizing theft or other things that will remain a crime. And my hope would be that diversion is always part of the response, right? Most people, and I think many law enforcement officers would say, they'd rather have a person's, kind of root causes and, basic needs met versus just doing another arrest. And that's not really going to solve things. So it's really more a combination of policies versus just how do we handle somebody in possession of a certain amount of drugs. At the same time, we have things like, do you have civil infractions or not, or just a referral process? Initiative 1922 ended up not having civil infractions as a response. And we heard from a lot of people directly impacted who said, you know what, that's probably not going to be a huge motivator for people. It could be abused, it could lead to other consequences like additional debt. And in Washington, if you don't comply with a civil infraction, it can actually be a crime. So Initiative 1922 didn't have that. It had a referral process and allowed law enforcement to seize drugs instead. Other tricky issues are things like, do you have threshold amounts or not for drug possession? That's a really tricky policy question. There's different ways, I think, to deal with it. Again, in I-1922, we ended up thinking that the case law standard in Washington is probably a good way to handle that. And what that means is, in Washington, you can't be convicted for drug possession alone, just based on, or drug possession with intent to deliver, just based on the amount of drugs that you have. You have to have some other evidence that somebody was, actually dealing, large amounts of cash, or observed selling, or scales and baggies, things like that. And I think that would certainly be a workable standard, because anytime you have a threshold amount built in, it's going to frankly be arbitrary. But that's a good example
Mark.
of just.
I
Go ahead.
just want to do a time check and make sure that we have some time for Q&A. So please feel free to finish your thought, but as the sooner we can move into Q&A, the better.
Okay, I'll go quick through these last thoughts. So the other one, state preemption. I think we don't want justice by geography. State law is good. Past convictions, you got to deal with some of the harm that's been done. Are examples. And then my last two thoughts, we can get to Q&A. No matter what the law is in terms of is possession criminal or not, until this state fully invests in alternatives and the services that people actually need, you're not going to have success. Is my true belief. You really need to build that alternative, and until that is done, we're not going to be successful. So if nothing else, I really hope we can do that. And then the last point, and this was a tough thing to realize, but until safe supply options are really being discussed, we're not going to have real success in this domain either. The fentanyl issue alone is so big, it's so awful, it is such a poison supply. I think the time has come to really confront that issue, and that is a safe supply question, no matter what the federal law is, and I hope that SURSAC really digs into that. So I'll end my comments there and would be happy to answer questions. Thank you.
All right, any questions for Mark? Please raise your hand.
Everyone, he's really smart. If you ask him a question, he'll give you a really good answer.
Brad, go ahead.
Thanks. Just a quick question, Mark. Appreciate your presentation. Around the safe supply issue, like, I am wholeheartedly with you that that's probably the only way to address this drug supply, this really contaminated drug supply that we have. I'm just wondering if, like, how a state recommendation would work with federal guidelines around and DEA standards around that, and if there is realistically a path through to get that implemented with state regulatory barriers.
Yeah, thanks, Brad. That's a great question. I mean, the short answer is we're at the beginning stages, I think, of identifying a safe supply policy answer that's really going to work. But I think there's some lessons we can learn from other contexts. And I would start with marijuana, right? I know Allison's on the phone here. When I-502 passed in 2012, in November, we had no idea if the federal government the next day was going to come shut it down, right? And they can enforce their law at any point. But I think they realize that, you know what, it is a balance between states and federal government, and that there has to be some balance there. So we're going to have to work through that. If it is a prescriber model, the DEA is going to be in the middle of it. But I think we have to start somewhere and start the conversation. And there can be creative ways to get around those issues. So I think the call to action would be, let's get experts together and figure out options for doing it. Because just allowing fentanyl to be the primary source of opioids for many people, I think, is unacceptable.
Thanks, Mark. Appreciate it.
Ted, and right, go ahead.
Hey, Mark, thank you. You mentioned in, I think it was the last slide, that the civil infraction wasn't a huge motivator for people. Was that a huge motivator for them to get into treatment? I guess that's how I took it. And what would motivate people to get into treatment?
Yes, thank you, Chad. I mean, I think it was two things, right? And I'm really excited that Tara Hurst is going to come talk about Oregon, and that even then you saw some real variability in terms of who was using civil infractions and were they motivating people. And I think the evidence thus far, and that could change, was that they weren't super successful. I think in Washington, our civil infraction law does allow people to be criminalized ultimately if they don't follow through. So that weighed on us. And then ultimately it was people that had been directly impacted by drug laws that said, this is just going to kind of make life more difficult for us. It's not going to be a good motivator. What I truly believe, and others can disagree, is if you actually create the low barrier alternatives, people will use them. They are rational, right? And it just can't be some one size fits all, abstinence-based only program that doesn't work for a lot of people. I think those should be options too, but I think you really have to create the infrastructure that's going to do the hard work of engaging with people, figuring them out as people, as humans, and then offering them the alternatives to what they are currently doing. And if we build that, I think people will respond to it. And I think if you talk to people on this call that do that work already, you'll have many, many success stories to learn from. So that is my hope. You can disagree with it, but I think that if you create the right alternative, people will engage with it.
I think we've got time for one more question, and then we'll move on to the Washington Lead Technical Assistance Team's presentation. Paul, go ahead.
Yeah, to my knowledge, and if somebody knows otherwise, I'd like to hear, I don't think there's any evidence that external pressure creates motivation for treatment. I mean, in isolated circumstances, like say a physician's going to lose his license, that's an external pressure that might have some success. But most of the people we're trying to address here who are most adversely affected by the system as it stands, I think are only motivated for treatment if it offers them something that they see as help, not because they're feeling pressured by various rules to comply.
Yeah, I agree with you, Dr. Greco, on that. I also see that Caleb had put a quick question in, thoughts on decriminalization versus legalization. What do they mean exactly, and what are the implications legally for people who use drugs? I mean, the technical difference I mentioned is that decrim just says that it is no longer a crime to possess something, and that's really all the law changes, whereas legalization generally is meant to be, it is decriminalizing that, but also creating some type of legal access to it where you can, actually sell it and do all these other things. And there's a whole gamut of what legalization is, right? I'd be very careful in saying that, alcohol is legalized, marijuana is legalized, but in a different way. And there's all sorts of, in-betweens there in terms of what a legalization model can look like. And that would be what really matters for a person who's using. It's legal. Maybe if you go get some type of prescription from a doctor, is totally different than we have a store dedicated that anybody of a certain age can go into to buy something. So yeah, I agree. It's very careful to be precise when you're talking about these various models, and really excited to hear some of the other speakers today get into more detail on that.
All right, thank you so much, Mark. And please feel free to utilize the chat with additional questions, but we're going to go ahead and move into the next presentation here. So I'll be running the slides. Whoever's presenting from Lead, please let me know when you're ready for the next slide.
Thanks, Michelle, and thank you so much for running our slides for us. Greatly appreciate that. And I think Everett is here with me with the rest of our team. Everett?
Yes, I'm here. I'm sorry. I'm thinking you're going to start us off. Thanks, Vanessa. Good morning, everybody. It's good to see you all.
Good morning, and thank you everyone for making this 3 hours this morning happen. We appreciate it. So the Lead team here is going to be presenting on maximizing pre-booking diversion and building consensus after Blake. And we're going to do some introductions on our next slide. So I'm Vanessa Martin. I am a site advisor with the Lead Washington State Technical Assistance Team. I'm also with the Whatcom County Prosecutor's Office and a member of the LEAD leadership team there. And we have joining us today, Lisa Dugard, Co-Executive Director of Policy with the Public Defenders Association. Rebecca could not join us today, but she was a contributor of this presentation and is the consulting expert for the LEAD Proof of Concept project. And then Brandy is with us, Brandy Flood, Director of Community Justice, Evergreen Treatment Services, REACH program.
We also have joining us today Malika Lamont, who is the director of the LEAD Washington State Technical Assistance Team and the project director of Vocal Washington. Malika has for years engaged in community-led advocacy and systems transformation to create more racially just policies and laws in order to shift how we respond to substance use in Washington and also to improve the lives of people of color and others who are living in our state. We're also going to hear from Emily Kanafis-Saran, who is a senior research scientist at the University of Washington with a PhD in sociology. Emily is an evaluation advisor to the LEAD TA team, focusing on identifying measures for understanding interventions, fidelity to the LEAD model, to ensure we maximize the benefits of the model when it is in use in the field, and to help identify potential areas for improvement or growth. And then I'm Everett Maroon. I'm Emily Maroon. No, I'm Everett Maroon. I'm the executive director of Blue Mountain Heart to Heart in Walla Walla. I run 2 LEAD model programs out here, in addition to other diversion programs, case management programs around substance use, and I'm a site advisor on this TA team. So thank you all for being here again. I'm going to continue to have my coffee and become more articulate as we go.
Thanks, Michelle. Next slide. Brandy?
Sorry, sometimes it's so hard to get to the mute button. It's sometimes the most challenging thing in my day. So hello, everybody. So LEAD tackles one of our most complex social challenges. And so I'm not going to read bullet for bullet, but when I think about that first tab about organizing stakeholders to serve people with very complex issues, I used to always say we need more core pathways to care, but we need more core pathways to just sustainable support. So that's everything. We've seen a shift in how things work after COVID, or I should say COVID shutdowns, because we're still in the pandemic. And so there's less resources, there's less spaces to support people, just less resources in general. And so you want to utilize all those community supports. And Mr. Cook talked about it a little earlier. We need more spaces where people could chill out, get resources, reverse overdose, all those kind of things. And so when you're thinking about this, we're dealing with the most complex people. We need more complex approaches. We want to reduce unlawful behavior and problematic behavior. That's one of the ways to do that. And we need more wraparound care that meets people where they are. And when I think about wraparound care, you're not just thinking about social services, treatment, just police. We're thinking about incorporating businesses and residents in a way that protects people's public health information, but you're going to need that overall village approach to support these very complex things. LEAD is a framework to be able to do that, and it improves the overall stability, social connection, and overall well-being of that. And so you're thinking about how do we do this in a way that brings in everybody to meet people where they're at, that is not punitive, that holds people accountable and has a community approach to that. And so LEAD tackles all those very, very complex things that there's not always an answer for, and it holds 2 truths at the same time. We need more supports. We're dealing with very problematic people who are vulnerable, and how do we do all that together in a way that makes it better on all of our systems? Thank you.
Next slide. So in LEAD, as we know, everybody is part of the solution. So part of bringing stakeholders together is making sure everyone is kind of pointing at the same problem and then creating solutions to those problems. This is a key task for project managers in creating that buy-in. And it's also, as these new project managers are launching programs throughout the state, it's deepening their understanding, and then they deepen the understanding of their stakeholders that they've invited to the table. And it's also implementing LEAD with Fidelity. So our Emily and Rebecca created the RNP and LEAD Fidelity Framework and Assessments. And this tool has been used across the state to ensure fidelity to the model, which has been a key resource for the new programs launching. And so, as we know, there's been essential groundwork that's been laid, and federal and state and local funds have been committed to this. So many of the programs have been scaling up. And I know Everett has been in his jurisdiction, and then I have been as well in Whatcom County. And we're seeing that throughout the state. Okay, next slide. Thanks, Michelle. So these are just a list of some of the really strong LEAD and AJA sites across the state of Washington that the TA team has been working consistently with. Some of them we're working with on a weekly basis, others monthly, and these programs launched, as we know, Seattle back in 2011, and others have been in operation for a couple of years now. You will see in this chart, some of them have LEAD/RNP, and that is because due to, as we know, 5476, some of the existing legacy LEAD programs are expanding due to that legislative effort. Okay, next slide. And just like our previous slide, this one illustrates some of the RNP sites across the state that have been doing quite well. And we also put in some sites that have been requesting LEAD that we will be working with as well. So just a little bit of what the TA team has been doing with some of the new sites is, development of the RNP framework and assessment tool that I mentioned previously. And this is a tool that sites get to use to ensure that they're staying true to the model and working within the fidelity. We have been working also on the composition and purpose of the policy coordinating group and the operational work group, which is essential to the programs, and bringing, again, stakeholders together to point to those problems and work towards those solutions together. We work in developing policies, procedures, and divertible criteria, and MOUs, charters, the list goes on. And what we're trying to deepen project managers' understanding is that we're working towards collective impact and system change. Okay, next slide.
So I'm going to be collapsing 20 years into 20 seconds, but the LEAD came out of a period of really intense and protracted division around drug policy that in some ways is reminiscent of the current time. And I think what's notable is that it originated out of a recognition and increased evidence of stark racial disparity in drug enforcement. This struggle happened to occur in Seattle, but it could have been in any American city. Seattle was not atypical in that way. But what is different and where LEAD came from was that at a point where empirically it became really impossible to contest that drug enforcement was focused on Black people really engaged not just in possession, but especially in low-level delivery of drugs, was that our police and prosecutor, now partners, then really litigation antagonists, sort of called a timeout and said, okay, can we talk about whether it's possible to actually step out of this confrontation and discuss doing something different? Because for their own reasons, not necessarily because they agreed with all of our analysis about what was happening, but because they had concluded that the use of arrest, jail, and prosecution was failing to have any significant impact on the problem. They were interested in doing something different and more effective. So LEAD's genesis is the imperative to confront racial disparity, but also a formation of a new consensus that actually we can do much better, and we all need to do much better. So the questions on the screen are the questions that we spent several years exploring, and LEAD was the agreed on framework for improved response to public order issues, reduction of crime, and reduction of racial disparity, both in and generated by our criminal legal system. I do want to make a quick comment in response to Caleb's question with Mark's presentation that the focus of LEAD from the beginning has not just been on possession, but on people trapped in the illicit economy throughout the distribution cycle. Most users who are confronted with the criminal legal system also distribute drugs, either for money or not for money, and under Washington law, it doesn't make a difference. So developing an alternative response to this population from our point of view has necessarily required providing a diversion opportunity for people who engage in distribution, not at a high level, not for profit, but at a subsistence level, not just possession.
Next slide.
Okay, I got nervous. I said, what happened? LEAD is not a program any more than law enforcement taking somebody to jail is a program. It shifts the collective system of response. And as a service provider, one of the most important ways to do that is to change the mindset of our communities. Take on the health of drug users. If we could change that mindset, we can have these shifts. It builds agreement around resource shifts and non-punitive investments that we need to advance safety. So we can hold people accountable without using punishment, and especially criminal punishment, to do that. It creates spaces for information sharing and care coordination and real deal care coordination. And so in order to do that, you have to make it a framework and not a program, because you need to be able to shift with what's shifting in the community, our politics, and the needs and the health of drug users. And more importantly than anything, it reserves the scarce legal systems resources, and they could truly put those investments in where they need to be. And so you have to have a framework versus a program, so you're not stuck in just A, B, C, D. It's about the whole system of care for drug users. And so it needs to be a framework and not a program, which is what LEAD is.
And part of that framework is having distributed leadership and sharing power in order to restore community. One of the beauties of the LEAD approach is that a part of that system that runway for system change means that there is a table that everybody can come to in order to begin to share ideas, start working together. Oftentimes, what happens is the partners that are brought together with LEAD have never really worked together before. They've never sat down and communicated. They may have been siloed in their particular areas, and the opportunity to build consensus and a path forward is created through this framework. That happens both in the policy coordination work group, where leaders from the community come together and develop the policy that will guide the project within the standards and guiding principles of LEAD. And then the operational work group is where individuals come together that are engaging with people in the community, and they're able to brainstorm, put their heads together, and develop creative solutions and share information about the individuals that are involved in the program. Active and meaningful community leadership is crucial to LEAD. It is important to have members from all parts of the community involved, whether that be business, whether activism on both sides of the spectrum, in order to create an opportunity to be able to communicate and put the priorities of the community and the lives of individuals forward. As Brandy mentioned earlier, it's crucial to take the village approach, because we're dealing with complex the individuals that we're working with are dealing with complex issues. And so therefore that means that we need to bring many people together to have complex solutions. Next slide, please.
Those of you on the call who know me know that I am always going back to the same sorts of concepts as someone out in another corner of Washington State to say, it's great if it works in an urban center, but does it work in a rural environment? Does it work in an ex-urban environment? And I think one of the really most accessible pieces of the LEAD framework is that it can work anywhere. It's scalable to different kinds of resource infrastructures that might be in a region. And even if there are gaps in that resource infrastructure, LEAD, because it's community driven, will really help anchor itself to the resources in the area and help people leverage and build new collaborations. And one of the ways in which this is implemented is really through the referral process itself. So there's no back door into LEAD. We have categorized these into a few major groups under arrest diversion. That is sort of the hallmark of the law enforcement assisted piece of LEAD, through social contact referrals. So we get those from all kinds of other partners in healthcare, in social services, and other organizations that want to partner and help the same broad caseload of folks. And then through community referrals. My phone must ring at least once a week with someone asking about the program on behalf of someone that they love or know, or sometimes even themselves. So all of these pathways in are part of how LEAD is able to work in such a agile way, no matter where it is located in the state.
And sorry, we saw the time note. I just want to comment that this means that the model fits under any legal framework. So the legal framework of 10 years ago, a decriminalization framework, a de facto decriminalization approach, or a legalization framework can all feed into this strategy for care and coordination.
Yes, right. And all we mean here with the note about predefined time limit is we're not trying to pigeonhole people into a program that doesn't respond to their lived experience and their situation. LEAD is flexible and is so committed to accessibility for the clients that it will take people without those kind of artificial limitations. We can go to the next slide. Next slide, please. So I'm sorry, go back to the LEAD care model, please. Thank you. So again, I'm not going to read the slide to you. Boy, you got to put me under the gun here, Michelle, with your time limit thing. What this really is about is setting up a system that is respectful and non-judgmental toward the people that it's trying to serve. A lot of people talk about case management. That's not what we're really talking about here. We're talking about a care model that asks individuals to participate in their own coordination along with the professionals who are helping them in a non punitive and a therapeutic environment. So all of these aspects of the care model are really set up to support shared decision-making process, motivate people through those stages of change. We talked a little bit earlier about how there's not a lot of evidence showing external motivation works, but we're helping people kind of identify their own internal motivation. We work on self-esteem with folks. We work on, helping people revalue themselves so that they're more interested in change. And I'm just going to throw it out there that change does not necessarily mean attention to getting into a treatment program. Change can mean all kinds of positive change for people. There's a very large universe of things. And so I just want us to be able to think broadly when we're thinking about how we're serving individuals and how that's reducing, some of the more negative impacts of their substance use. Next slide, please. So LEAD is not a quick fix. It's not a panacea. We didn't get here, overnight, and we don't get out of it overnight. But I think one of the things that's really valuable, if there's a takeaway, comment that I can make, it was system-based policy and law failures over decades that got us to this point. And if we're talking just about care coordination or case management, light case management, we're talking about individual level interventions. But the LEAD framework is a system level transformation intervention. Again, yes, we still see individual support for people who would otherwise be caught up in these non-therapeutic institutions. But because LEAD is asking for collaboration and partnership among stakeholders in the community and people with lived experience, it's actually changing how communities understand substance use, helping each other, helping the people in their communities at the enterprise level, at the system level. And so in that way, LEAD's ability to connect people together to help us strategize and collaborate and work together toward shared goals really is the thing that's so revolutionary about this approach that we don't see in other interventions, quite frankly.
And Michelle, we're going to jump
Yep.
to 2 slides. So, and then we're summarizing, sorry.
Yep.
Let's see, maybe one more. Well, we'll stop here, but we'll let Malika summarize.
So in essence, what we're saying is that it takes a collective approach, and LEAD is a framework by which that can be achieved at a systemic level as well as at the individual care level for people that are engaging in public disorder related to their behavioral health issues and poverty. It is a framework that creates complex solutions to complex problems.
Thanks, Malika. Thank you, Michelle, for running our slides. Greatly appreciate it.
Great, so I'm going to go ahead and open up to questions now. There is one from Julian Saucier in the comments already. How can we learn more and see examples of LEAD and or stories from people that have benefited?
I'm going to put a couple of links in the chat.
Thanks, Lisa.
We've got time for probably one more question before moving on to the next presentation, if anyone has questions for LEAD.
Just commenting, oops, sorry, turn my video on. Some of the questions in the chat make total sense about why don't we have this in my community? I don't think that, the Recovery Navigator program is playing out around the state in different ways, and in all instances, except where it's actually just feeding additional resources into existing LEAD programs. These are all at micro demonstration level. So in no community, including Seattle, is LEAD operating at scale such that it's a system that can always respond as needed. But in Seattle, we're a little bit closer to that than in any other community. So it's really important to recognize empirically that saying that this model could be the receiving system, we are not saying it is the receiving system. It is not scaled, and there's been no plan for scaling to system level. One of the best things that the criminal legal system has going for it, honestly, and why people find it appealing is that it's always open, and at least theoretically, it can always come. And alternatives are not scaled in that way, and that's the gap. And that's so important to recognize. So I'm seeing lots of evidence of that in the chat, and it's just absolutely correct. There's a reason that there's no visibility of these things in your communities.
Thank you so much for that presentation. Next up, we have Adam Paliu with the University of Washington to discuss different models of safe supply. Adam, are you on?
I am. I'm just trying to get my stuff to work.
Okay.
Can you hear me okay?
We can, yes.
And can you see me?
Can see you, yep.
Sorry, Microsoft Teams always makes my computer a little slow. So I'm just trying to get it to work here. Thank you for bearing with me. But yeah, so as we wait, my name is Adam Paliu. I am a third-year PhD student at the University of Washington. And I'm originally from Canada, where I am involved in some safe supply work up there. We're hoping to do some safe supply work in the United States around different models and preferences, which we'll discuss about today. And I've also done some harm reduction work. I've done some work with Vocal. And so, yeah, it should be good. And I'm looking forward to presenting to you today. And I appreciate having the opportunity to speak here. Sorry,
Would you prefer if I pulled up your slides?
Sure, that would be great. I'm having Microsoft Teams is taking a lot of the bandwidth on my computer.
Yeah, no problem.
Maybe the Canadian version of Teams doesn't work as well in America.
Yeah, it's always a version that's a little light. So again, hi, my name is Adam, and I'm here to present to you on safe supply. And so this slide here that's up is notable people who died of accidental fentanyl overdoses. And so there's Prince on here, there's Tom Petty, as well as a lot of younger people like Lil Peep and Juice WRLD that some people on this call may not be familiar with, but they were around 22, 21 when they died of accidental fentanyl overdoses. The youngest person on here is Jake Ellinger, who's the Texas linebacker in the lower corner. He was 20 when he died of an accidental fentanyl overdose, thinking he was taking Xanax. And so if you want to go to the next slide, this here is just to highlight the immense loss that we've had in a very small way. And so as we can see from the graph in the bottom is that Washington recently has had fentanyl overdoses increase a lot, especially for those, even for those both under and over 30. But really, there's been a huge increase in deaths among those who are under 30 compared to what they were dying from before. And a lot of this has to do with accidental contamination of the drug supply with fentanyl, as well as an unpredictability in the amount of fentanyl in each dose, where people kind of describe using as sort of a Russian roulette. And beyond just fentanyl and the drugs, I think it's really important to highlight, if we look at this drug report of a drug that was tested from someone who died of overdose in King County, they had a blue powder, which was presumably fentanyl, but the most common ingredient in it is acetaminophen, which is Tylenol. Then it's fentanyl. There's methamphetamine in it. Edazolam, which is a benzodiazepine, is in it. There's tramadol. There's cocaine in it. So there's basically everything in it. And so it just shows that how fractured and how contaminated the drug supply is. So even if you think that you're getting fentanyl, you're actually getting a bunch of other things as well. And this is also vice versa is true with other drugs. And so just to highlight is fentanyl is the drug of the day that we've been talking about. It's the one that's causing a lot of the issues. However, the supply will shift and the supply will change especially as enforcement happens around fentanyl and we decrease the amount of fentanyl coming into the country. Drug dealers will shift to other methods and other drugs. And we've seen this happen from heroin moving to fentanyl, and we'll just see it again. So it becomes a bit of a drug whack-a-mole with enforcement. And this is kind of why we have such a fractured supply. Next slide. So one solution that's been proposed to this is safe supply. And you've heard a lot of safe supply. And so this is the definition of safe supply that was put forward by the Canadian Association of People Who Use Drugs, or CAPUD, in 2019. And it's defined as a legal and regulated supply of mind or body altering substances that traditionally only have been accessible through illicit markets. And so safe supply, the idea is that it directly reduces the exposures to drugs on the street for people who use drugs, making it really safer, a lot safer, and reducing their overdose risk. And throughout the presentation today, I'm going to talk about different ways that safe supply has been implemented around the world and in Canada, as well as the evidence that supports it. And the logic behind it is very similar to the regulation of alcohol post-prohibition, where after prohibition, alcohol deaths dropped precipitously in the US. And it was because instead of having 80% alcohol from a bathtub, you had like 40% Jack Daniels, or, you know, your can of Rainier, instead of something between 2 to 20%. And not being able to know that, we would have similar issues, and have had similar issues with alcohol as we do with the current drug supply that we have now, such as opioids, methamphetamine, and cocaine. Next slide, please. So safe supply has been shown to greatly reduce the chance of overdose for those who receive it. Brothers and others in 2022 showed this in Halifax. They prescribed more than just opioids, which is commonly what is prescribed for safe supply, but they also did benzodiazepines, methamphetamine, cocaine for people. And they found that there were no overdoses among the people who participated. And then including that, it was in a COVID isolation shelter, and they found if people's needs were being met, they weren't leaving. So they also found that it actually had other public health impacts and also helped them get into housing and stay in housing, because they weren't going out to go and try and find their drugs or commit crimes to go get their drugs. And then this other study that I have here is by Young and others. It's from Ontario, Canada, and they showed that those who engaged in safe supply, their use got safer over time, and they switched more to like smoking or snorting, especially when they knew that they were able to reliably get the drug, so they weren't rationing it, and they were switching from injection to safer use methods, as well as 70% of people reported committing less crime of who engage in this program, and they weren't committing crimes to be able to like get their money for their drugs, since they were being supplied to them. And so this goes to the other thing that I wanted to share, which is the Government of Canada has a very accessible overview, which could be clicked at the hyperlink there for those who want to see it. And the Daily podcast from the New York Times recently did an interview on safe supply that I think is really accessible to people, and that a lot of people would find interesting on this call, and would answer potentially some of your questions. And I just want to also highlight that those who have engaged in safe supply on average have gotten their lives back. They say that it's a lot less chaotic and that they're a lot safer. Next slide. So this is 2 qualitative studies that have been published, and I'm just showing the titles because qualitative studies titles normally give it a pretty good quote. And in the first one, it says, "People need them or else they're going to take fentanyl and die." And then it says, "It helped me a lot just like to stay alive." And this talks about people who are able to access versions of safe supply that have come out, and how they were able to, and how it changed their lives in terms of getting them away from the street supply. And then here there's someone at a protest in downtown Vancouver who has a sign that says, "I'm alive because of safe supply." And we've heard this by tons of people. Next slide, please. So we have talked about safe supply, and hopefully you understand it a bit more as a concept. I'm sure some people on the call think this is probably one of the most outlandish ideas they've ever heard, but it's very similar to how we approach alcohol. And so I'm going to now go over the different models of safe supply that exist around the world. We're going to talk about a prescription-based model where you have to use on site, a prescription-based model where you have to do a take-home doses, one that's through a community-based organization, all of which are ongoing, as well as a potential alternative model, which is dispensary-based distribution. And in terms of this table here, this is for your reference. for later to be able to compare different models of safe supply, but it's a bit more dense information that we're going to go into now. So next slide, please. So the first framework is a supervised prescribed model. In the pictures on the bottom right, you see someone preparing a dose at the clinic. In the top right corner, you see what a typical clinic could look like. And people for the supervised prescribed model, only for people with a prescription are able to access it, which means that you need a diagnosis. And traditionally, this is a substance use disorder diagnosis. So people accessing this model, none of them, there's no people who are accessing this model who don't have a substance use disorder diagnosis. So you're not talking about any new people using drugs through this model. You have to use them on site. Possession without a prescription and underground sales are still very much illegal in this market. And this has been going on in Canada and Switzerland for over 20 years now. There's randomized controlled trial evidence that shows that this works, published in some of the most prestigious journals, such as the New England Journal of Medicine and the Journal of the American Medical Association. Again, hyperlinked for your reference. And this model was also in the UK from the 70s to the 90s until they shut it down due to political reasons, but was incredibly successful. And the limitations, though, with this model is the access to the model, and we'll talk more about the issues. But in this model, substances are still criminalized. So you can have legal access through a prescription without having drugs broadly decriminalized and implement this model of safe supply, which has been going on in other countries for over 20 years now. Next one. So framework 2 is prescribed and take-home doses. So very similar to how some of us take our medication. You go, you pick it up at the pharmacy from your doctor, there's a prescription. You need that diagnosis again. So again, it's only people who are able to get this medication is from people who have a substance use disorder diagnosis. And what happens in this one is you take them home with you. There's a level of trust here. It's very similar to take-homes with methadone. And this was recently allowed during the pandemic in Canada and Switzerland with very early promising, with early results that being very promising. So in the bottom corner, what I have here is odds ratios from opioid risk mitigation guidelines. That's what RMG stands for. And what they found was with certain definitions, if you were on you had 4-day take homes, the bottom one and the bottom dot on the bottom, you have a 90% odds decrease of overdose if you're on safe supply compared to those that are not. And this is a striking finding that there's such a huge drop in overdose death directly. And for those, the PS and the HDPS stand for propensity score and high dimensionality propensity score. And that's essentially just to make sure that the people you're comparing actually do match up to each other. And so that you can actually interpret these numbers as a reduction in odds. And so this has been successfully implemented, this take home in Ontario from that Young and Others reference, in Halifax from that Brothers and Other, as well as British Columbia's unpublished data, but that should be coming very soon. And what they've found is that there's not been an increase in overdoses, and there's been this very, very large decrease for those who've been able to get it. Next slide.
And Adam, we're at time. Go ahead and finish your presentation, but just wanted to let you know.
Okay. There's issues of prescription models with SUD diagnosis. So who is getting it versus who needs it. So there's a lot of people who use drugs but don't have a substance use disorder diagnosis, and they won't be able to access safe supply in these models. There's need for a substance use disorder diagnosis, which can negatively impact someone if it's in their medical records. Prescribers need to be willing. Mark touched on the issue of the DEA being in the middle and law enforcement, but there's ways around that. And then the diversion of medication from these programs is a very real concern. And some argue there's a benefit, others argue there's a really big danger. And the reality is, and we could discuss more about this, but it's somewhere in between both. Next slide. This is a community-based buyers club model that's being done where people in the community pool their money together and then they buy drugs, they test them, and then distribute them back out. This has been successfully implemented at a small scale in Vancouver. It's very much illegal right now, but it's been very successful, and they have distributed over 150 grams of drugs back to the community with 0 overdoses. Next slide. This is a dispensary-based model. So this does not exist anywhere in the world for opioids, methamphetamine, or cocaine. However, it is a potential model to consider, as this has been successfully implemented for alcohol as well as for cannabis. And these can be done in a profit or a non-for-profit manner with different ways to think about it. Next slide. So there's many different frameworks that exist. Don't be just limited by the 4 that I presented. So there's like communal grow, there's home grow, and there's active work in British Columbia now about thinking around different models of safe supply and what those alternatives could look like. Next. And features that can be implemented in any framework are licenses for people to purchase it. So we could provide required education, labeling and packages, legislation around the doses that are allowed, such as with cannabis edibles, where there's a limit on the amount of dose that you can have per single serving, as well as you could have direct co-location of these services of safe supply with education, as well as harm reduction supplies, making it safer for everyone. Next slide. This goes to the legalization versus decriminalization aspect. I think for it to be truly successful, both are needed. Decriminalization removes a lot of interferences in people's lives, but decriminalization does not change the supply of drugs. And changing the supply of drugs, as we've talked about, and as I'm sure a lot of you understand, is incredibly important, because what people are taking is poisonous and they do not know what's in it. And that's what's really leading to a lot of deaths. Next slide. And so there's ongoing work of interest. Like I said, there's evaluations ongoing in Canada, thinking about different models. There's some of the work that we're doing in King County, collecting preliminary data on preferences of the 4 different frameworks that we presented, as well as plans to do some modeling to see the potential impact of the 4 different safe supply models, which I think y'all may be interested in. Next slide. So in conclusion, there's a lot of evidence that shows safe supply reduces riskier use at individual levels, less crime with certain models of safe supply. There's less overdoses immediately, so this reduces less 911 calls, ambulance dispatches. There are different models of safe supplies, all with pros and cons to consider. And I believe that safe supply is needed as part of a solution to be most effective, but would reduce overdoses significantly, even implemented on its own, as we can see from evidence that's already been generated in Canada and Switzerland. And just the final thing, because I think it's really important, is the toll of life that has been lost is incalculable. And I know a lot of people on this call, including me, have been touched by it. So this is a work of street art that was done in Vancouver by this really talented artist named Smokey D. And he says, "Rest in peace to my wife, soulmate, Dawn Heather Sangster. Fentanyl stole her life. Please don't party alone. I miss and love her more every day." So thank you for your time. I'm looking forward to, I think we have some Q&A now. So yeah. Sorry for going a little over time.
No worries. Thank you, Adam. Go ahead and raise your hands for questions for Adam. Paul, go ahead.
Adam, thanks for this. In our last work together, you did a lot to convince me that this is definitely something that we should do. So I'm fully behind the safe supply model. But I do have a couple of questions. One of them is, has there been any research on basically diversion? So you can look at the reduction in death among people who participate in the program, but how about people out in the community? So that's the first question. And the second question is a question about scale. I can see this being extremely helpful for people, but at least my knowledge of the programs in Vancouver, in Zurich, is it's really only a small number of people. And given how big this current epidemic is we're in, I think it's important to do everything we can, but it's also important to be realistic about how many people we're going to affect.
So thank you, Paul. Always great to see you. So those are both two really great questions. So the first question about diversion, there is ongoing work to try and find the answers to those questions. It's very hard to evaluate because then you need to go and find people who got these diverted medications, which isn't always easy. There is some qualitative research around it, nothing quantitative, but the qualitative research is focused around, which some of it I presented, is some people were getting diverted medications and it was actually safer for them. And some people call it diversion. A reframing of it would be like secondary safe supply or secondary treatment where people are getting it. However, there is a real concern that people could be getting these medications and then using them, and the new people using them. But I think the alternative is that they would just be accessing the street supply instead of these medical grade medications or drugs. And the issue becomes is that someone who's accessing the illegal supply is at a much higher chance of overdosing and dying and not knowing what they're putting in their body versus one of these diverted medications. So I think diversion is a real issue. It's really hard to quantify. I think there's both benefits and negative consequences to it. And in some of the ongoing modeling work, there are going to be threshold analyses built in around diversion, where it's like, what happens if 50% of drug use increases based off these models? What happens if 100% increase? What happens if there's a 150% increase in people accessing these drugs? And so you can kind of change the amount of people that will increase and see at what point where your model would say that more overdose deaths are happening because we're implementing this. And so you can kind of get at a number of what percent increase would need to happen to get to have diversion be an issue where at a population level. And then the second question is scale. So I think scale is a huge issue. It's been tremendously successful for those who've accessed it, but however, as they've tried to scale it up, there's tons of barriers. Some physicians have not been willing to prescribe it. They say it goes against their Hippocratic oath. There are pharmacists who refuse to fill prescriptions. It's hard for people to access it. It's only to people with a substance use disorder. So I think thinking boldly about models that are widely accessible to people in terms of regulating like cannabis and alcohol is kind of how you're going to have the most scale and impact. However, that also comes with, that's also kind of more extreme on the scale of options that we have for a safe supply. And I think the prescriber-based safe supplies can be thought of a lot as a continuation of treatment, as we've talked about before, where if you're giving someone heroin 3 times a day or twice a day, similar to how you're dispensing methadone, you need to dispense heroin more because it's a shorter half-life, but you basically have just another option for treatment for people.
We have time for one more question and prioritizing SURSAC members. Chad and Wright, go ahead.
Hey, thank you, Adam. You had mentioned the prescribe and take home method, and then I think you just sort of alluded to some of the maybe difficulties with that and having doctors willing to prescribe and pharmacists. Are there places where that is successful right now? And the reason why I ask, and again, you sort of alluded to the politics of this, just looking at my community, I can't imagine a location where a clinic could go in where there wouldn't be total outrage by the neighborhood. So I'm kind of intrigued by the prescribe and take home. And so are there places where that is being tried?
So I think there's a lot of really good things in there. And thank you for your question. So I would say for the first question is yes, it's been tried in several places and it's been very successful. So Vancouver is one of them. I presented some of those results. There's published data from Switzerland where they found that both by relaxing the take-home requirement instead of having people to come to the clinic every day, they both increased the number of people they were able to expand it to because it allowed it to more people to accommodate it in their lives, as well as they didn't have any increase / they didn't have any overdoses in that program. So I think there are places where this is happening. It's being done successfully. I think there's multiple places in Canada. And those references and evidence are in the slideshow. On the other hand, you're talking about, the political reality of this. And would it be acceptable and all of that? And I would say you can't know until you try. I would completely agree that there will be a ton of political backlash if one of these are implemented. I think we could all see the headlines already of what would happen. Someone made a comment in the chat about who is actually, dare I ask, who's paying for this? And I would say that implementing these, as I said, they end up being cost saving, these programs, because you're reducing the burden on the medical system. And a lot of this evidence now is going to be coming out showing how cost effective or cost saving these programs that have been operating for over a year now in other countries, and what's the economic impact of them. So it's definitely a tough sell. There will definitely be political opposition. But I think people's lives are at stake. I think this is something that's been shown to be successful, that has a lot of evidence behind. And I think we should be doing bold action and thinking boldly about how do we keep our community safest. So yeah, thank you for your great questions, and thank you for having me again.
Thank you so much. So Tara Hurst is going to be coming on at 10:30. I apologize for the 10-minute disparity with the agenda there. Perhaps we can spend the next 8 minutes doing Q&A with the presenters that have presented so far. If there's any other questions from SURSAC members or other attendees, this would be a great time to ask. And then we'll move into Tara's presentation and Deontay's after that. Trying to see hands here. Amber Daniel, go ahead.
I was just wondering, maybe this is a question for Adam, where any supply testing options would fit into any of these models, like options for testing street supply?
I just quickly, if that's okay with the committee, I would say that testing for the street supply is really important, because people would still be using the street supply in some of these models. So having those options to empower people, I think, is really important. But but drug testing is kind of a reaction to the fractured street supply and how dangerous it is. So we don't go test our alcohol, we don't test our cannabis, we don't test our coffee for dosage. And so in an ideal world where safe supply is properly implemented, drug testing, I think, could take a back seat, which again goes to reinvesting resources that are allocated for different interventions to things that could replace it. So that's kind of where I see it fitting in. But I think drug testing is a really important intervention to have for people.
Thank you.
Thank you. Kurt, go ahead. Oh, sorry, is Kurt's hand? Yeah, Kurt, go ahead.
Yeah, a question for Adam. With regards to this safe supply, which kind of makes sense, and I'm totally not in this world, but my question earlier in the chat was, is there a reduction then in crime, in burglaries and law enforcement issues in those areas where a safe supply was created? And then based on the last comments you made, also is one of the metrics the number of individuals who have been diagnosed as or have become addicted to those drugs? Because safe supply is great for those who are already in that world and who are already addicted. But if the safe supply is promoting and all it does is create more addicts, then I'm not sure that that is quite the direction we want to go. But I do like the idea for for addressing the people who already have that addiction?
So in terms of the reductions in crime, thank you for those great questions. I would say there hasn't been any spatial analysis, so where they look at like the neighborhood level and these programs. However, the data that I was referring to is they directly asked the participants, being how much did you commit more crime, less crime? Did you commit any crime as well to get your drugs, and asking how their behavior individually changed. But there hasn't been any, for Safe Supply yet, any neighborhood level studies that have been done around crime and burglary and law enforcement and all of that. So there's only the individual level data as of now. And I would say it's always really hard to look at the neighborhood level data to then extrapolate to the individual level, because there's so much going on that influences what's happening at that macro scale. In terms of Safe Supply, for those who don't use, I agree that I would say you need to think about the alternative. So I know it could be a little uneasy that people need to be accessing these, people who don't use drugs could be accessing these drugs. But if we think about our 20-year-old linebacker who died, right? Prime of his life in college, he used the street supply where he didn't know what he was getting. And that's truly the alternative to the Safe Supply, is our current status quo, where people are accessing an illegal supply that is very fractured, that has a ton of contaminants. And so we need to be making the decision is, are we okay? It may be uncomfortable, but are we okay with letting people use drugs, knowing that they're going to use drugs, and give them a safe alternative, similar to like what we've done with alcohol? And Rep. Davis made a really good point about the commercialization of alcohol, which I think is a really important point. Like, we need to think about how you legalize these in terms of restrictions on advertisement, restrictions on making profits, because when these were more widely available in the early 2000s, there was a lot of deceit in advertisement that was going on, and it was really dangerous and really damaging to the public health. And so I think we need to be very careful, like you said, in how we legalize this and offer a safe supply, thinking about designing these systems to better the public health instead of making it so that it's kind of like a capitalistic feeding frenzy, is what I would say. I hope that answers your questions.
Yes, thank you.
Okay, Michelle stepped away for a moment. So Brad, it looks like you're up next, and we have about 1 minute until our next presenter. So Brad, did you have a question?
Yeah, a couple of just things real quick. I mean, let's remember we've had Safe Supply for 70 years, right? And that is in the form of other treatment medications. So Safe Supply isn't really Safe Supply, it's medications, right? Like methadone is a full opiate agonist. All we're talking about is other types of full opiate agonists. We're just trying to fight a fight of a brand new super synthetic high potency drug with tools that are 70 years old. And all that we're talking about is bringing other tools and other medications into the mix. You know, the reason why we're in this problem of fentanyl, and especially in counterfeit pills, is because we did so much to ramp down on prescribing practices that we took a fully regulated supply on and we got rid of it. So we created this inadvertent marketplace for really contaminated drugs. You know, in public health, one of the questions I get all the time is, well, do we have fentanyl and marijuana? And that is such an easy question to answer here in the state of Washington. And the answer is no, almost across the board, no. And the reason is because we have end-to-end like quality control on that. When we don't have end-to-end quality control, we create this marketplace for this really, really toxic drug. And yeah, so anyway, those are my 3 comments.
Thank you, Brad. And Michelle is back. It is 10:30, and I believe we need to move on to Tara if she's available. Michelle, I'll turn this back over to you.
Yeah, I just want to make sure. I know Tara had a meeting right before this one, so it may be another couple minutes before she can join us. Tara, are you on? And if not, if Deontay is on, we can swap those presentations to keep things moving along. Deontay, are you on right now?
I am.
Okay, great. Would you like me to present your slides?
Yes.
Okay.
Hello, everybody. My name is Deontay Damper. My pronouns are he, him, his. I am the community organizer for Vocal Washington, as well as the project manager for CDO. Oh, where'd it go? Oh, there it goes. And I'm also a person of lived experience. And today I'll briefly be going over Washington state drug laws, racial disparity, and the impacts. Next slide, please. I kind of want to go back in history a little bit. In 1965, President Johnson produced the Law Enforcement Assistance Act, which authorized for the federal government to take a direct role into militarizing local police in community. In 1968, Johnson also produced the Safe Streets Act, where he invested $400 million in the war on crime and created the Law Enforcement Assistance Administration to oversee us in that space. Now, even though these communities, right, aren't the only places where drugs could be found, low-income communities were negatively targeted by these actions. So seeds were beginning to be planted in our communities with policy to affect Black and Brown people. Next slide, which turned into the disparities of incarceration. Former President Nixon, everyone's favorite president, former president, set in place the modern USA drug policies, which has pretty much been the driving force of mass incarceration and the disparity towards African Americans. It's pretty apparent with its implementations that it was designed to actually not only criminate us, but also disrupt minority communities. You can also see by this quote by his former assistant, which pretty much said, as long as we were locking up hippies, connecting hippies to marijuana and black people. You all right, Michelle? Okay, cool. As long as we were connected hippies with marijuana and Black people with heroin, we were doing the job. And the main goal was just to continuously lock us up. So next slide, please. So when we talk about implicit bias in our communities, I mean, to be pretty frank, like Lady Justice isn't blind. The systems continue to show us that Black and Brown people continue to be affected by implicit and explicit bias. Simple possession statutes of the drug war pretty much just demonstrates the continued disparity and impact on minority groups, i.e. Black people. Next slide, please. Okay, racial bias is the only possible explanation for racial disparities in sentencing. Researchers have also raised the possibility of differential access to resources such as legal, psychiatric resources, and the availability to arrange paid for alternative schools also contributes to those sentencing practices. Next slide, please. I messed up on this slide, y'all. I'm gonna keep it real, right? I messed up on this slide. This is also this is talking about how it also impacted the youth in our community. I got this from Ferguson and others, where disparities in punishment also extended to school discipline. Evidence suggests that stereotypes about young Black males held by teachers, administrators, and possibly even internalized themselves by the student themselves contribute to those disparities. That stuck out for me because I think that even when I've been in rooms such as these SURSAC meetings, that I've internalized those stigmas, as I'm talking to having some of these conversations about how my community is impacted, knowing that some of you don't have that specific lens. And sometimes I've kind of been pushed off, and sometimes I internalize that as that this isn't my space. And I just want to make sure that when I seen that, a tear came down my eye, because it's like that's how sometimes I feel in a room, because I have a lived experience about my drug use, or drug use, or because I'm a queer Black man. Am I filling in a box, or are we really going to be in a space where we're really advocating and protecting and building our community? But I am here, and it feels good to say things like, next slide, please. So, thanks. So, we already know that enforcement has had drug laws out here since the 70s. Well, rather the 60s, right? Disparities throughout the systems have been sustained, reinforced through policy decisions, much like the process and policy decisions being made by SURSAC and the Blake decision. Criminal and legal system involvement is a social deterrent of health, and compounded by racism that deepens health disparities, compounds individuals' access to housing, education, and meaningful connections to community resources. Next slide, please. Michelle, you're doing a great job. If only I was doing a better job over here. Okay, right, thanks. And keep in mind, Washington State, we talk so much about how we are advocating for folks, and I think that we do an all right job, but when it really comes down to it, African Americans, we're about 3% of the state's population. However, 50% of us are incarcerated for drug offenses. They're us. They're people that look like this, right? And then at the end of the day, only 4 other states have a higher rate than Washington State of incarcerating African American men. I'm sorry, I'll say that again. Only 4 other states have a higher rate than Washington State of incarcerating African American men. That's a lot to take in. I mean, just when I look at just the fact that we only make about 3%, and of course we go through things like well, besides the systematic laws that have been put in place with policies when it comes to simple possessions, while you got buildings like Uncle Ike's that are up there in the very spaces where we already gave the blueprint, and some people are still locked up for those simple possession of weed, or so next slide, please. Okay, hold on one second. Now, to an extent, the decriminalization measures free up drug and enforce resources. They can inadvertently increase arrest for drug deliveries and other related offenses, which carry serious penalties. Therefore, by amplifying rather than reducing racial disparities, consistent with Ms. Beckett's analyzation of this, some studies suggest that decriminalization does not lead to arrest by itself without further systematic change. Next slide, please. If I'm going too fast, y'all let me know. I have a tendency of talking fast when I'm nervous, so please excuse. Okay. I thought I had a note for this, sorry. But the war on drugs is not just in the areas of affecting kingpins in this space. The war on drugs is a part of a long pattern of white dominance over Blacks. Efforts to disrupt the drug market through law enforcement have not reduced the supply of drugs, but we often trigger what we end up doing is offering competition and violence, triggering that space. More generally, there are more evidence that the war on drugs reduces. There is no evidence that the war on drugs reduces crime. Next slide, please. So even though like the legal system involvement is, as I stated before, the legal system, the only thing that it does is create more racism and stigma within our community and deepens health disparities. Criminalization over recovery constantly happens in our community. I heard someone say something about a safety consumption site, or I don't know if we would ever have this in our area. Well, it kind of needs, these conversations kind of need to be in every area. And that's really all I have for this slide. Next slide, please. Okay, yes. Okay, end criminal penalties for simple possession and implement lead statewide. All people deserve equitable treatment and access to services. We should remove systematic barriers by decriminalizing simple possession. Support individuals experiencing behavioral health challenges. Narcan training for all schools, all agencies, and local stores, and nonprofit agencies, of course, and libraries. We need to continue to build more partnerships with service providers and develop relevant services to access to all genders and community members here in Washington. We can actually build a healthier community. Next slide, please. So we do have an opportunity to do better. This final slide is recommendations from the Overdose Emergency Innovative Recovery Task Force. We suggested a comprehensive way to move forward out of this prohibition-based system and to more public health focused space. And yeah, and that's all I have. We all, oh no, I think I have one more slide, don't I?
Looks like that's it.
That's it. Okay, well, in closing, as I stated before, you know, being in these rooms for the past couple of months has probably been some of the most challenging conversations because for me, it's triggering. Because I know that, yeah, we have a lot of work to do, and yeah, it'll take 5 to 6 years. But I've been losing every week when I come into these meetings with you, I'm losing another friend. Every week when I come in here in these spaces, one of my friends is getting sentenced. And I think that with these meetings, if we continue, if we just continue to implement more, hell, if we could just continue to show up and actually really authentically listen to each other. I don't want to be a box that's being checked off. Because as much as I'm being a box that's checked off, so are my friends in the morgue. And that's all I have to share. Thank you.
Thank you so much, Deontay. So now we're going to have 10 minutes for Q&A. Go ahead and raise your hand. So, was there another? Did you want to add? All right, go ahead and raise your hand if you've got questions for Deontay on this topic. Amber Daniel, go ahead.
I just wanted to say that I don't know about anybody else, but when he said that another one of his friends was getting sentenced every time he was on here and the sirens went off, I got like goosebumps. Like, thank you for your presentation, Deontay. You did a wonderful job.
Thank you.
Deontay, I just had a question. You know, while you have the shot callers in the room, we never want to sleep on this. What would you say to our state representatives, you know, that are still kind of stuck in making the same policy over and over and again? What would you say?
Authentically?
Authentically, that's the only way we want you to be.
I mean, really, when it all comes down to it, it's like our communities are being impacted. Let's take the privilege mask off and actually really get down to business. Black people are impacted. Policy was built off of race. A lot of these policies were built off of racism to break families down. My family is just now starting to rebuild from the crack epidemic, okay? Still. Which led to me, as my family got out of the healing generational curses in the crack epidemic, I dealt with the meth addiction. My grandfather dealt with the heroin addiction. Every time we made ourselves out of this space, we continue to try to break generational curses, but there was a generational area of substance use. If people had an opportunity, if my grandfather and my dad and mother had an opportunity to be in the room, I think we would be trying to find better ways to just talk about the wellness and healing in our community. And I think that we just have to take more time of just actually really getting to, don't utilize this space as a salary space. Use this space as an opportunity for you to learn. There are so many privileged people on this phone, and I appreciate everybody for being here, but let's keep it real. We're more than just a box check. This crap is happening to Black and brown folks on a daily. I am losing friends in Federal Way, and you guys got all the resources going out there to the north end. I mean, either way, when it comes down to simple possession, when it comes down to access to fentanyl test strips, when it comes down to education for my community members on methamphetamine, we don't have it. And it takes HEA, it takes the SURSAC committee, it takes city council representatives to get with the program. Because we're constantly losing people, and even in our rural counties. Don't let Amber tell you, she can sit here and tell you constantly what's impacting our communities. This is happening. And it's not just happening in the areas, well, yes, it's happening in Washington State, but we have other indigenous community members it's impacting them as well in the areas of possession and overdose. And quiet as it's kept, it could have been me. So that's all I have. If anybody has any more questions, please feel free to give me an email, deontay.damper@vocalwashington.org. Thank you very much for having me.
Thank you, Deontay.
Yes, thank you so much. And I believe that Tara has joined us now. So I'll stop sharing the other presentation. And Tara, if you want to go ahead and begin, you are welcome to do that whenever you are ready.
Have my presentation, or do I need to be sharing a screen?
If you can share the screen, that would be great. I can do that for you. Just give me one moment.
Okay.
Because I've got that.
I've been bouncing, as we all do, from presentation to presentation, and so my screens are a little bit of a mess right now. All right. So thank you for inviting me here. My name is Tara Hurst. I'm the Executive Director for the Oregon Health Justice Recovery Alliance. I use she, her pronouns, and just a little bit, I was asked to come and talk about what's happening with your neighbor down south after we're almost at the 2-year mark of voters passing ballot measure 110, which was, just as a reminder, we decriminalized small amounts of all drugs and have diverted a large portion of our marijuana revenue to addiction recovery and harm reduction services. And the Health Justice Recovery Alliance is an advocacy organization that's fully focused on implementing Measure 110, with really centering the needs of communities most impacted by the racist war on drugs, which Deontay was talking about just before me. So we really want to make sure that, since criminalizing substance use has really led to more suffering and death, and we have incarcerated more people and more people are addicted at this point, we recognize that the war on drugs is a failed policy, and really trying to shift to ensure that we can create more safety, dignity, and health for people, whether they're actively using drugs or on a pathway to recovery, and really advocate for everything from harm reduction all the way to, kind of what we know as recovery, and make sure that there's not one emphasis on one without the other. It's a continuum. Everybody's on their path, and we've got to make sure that we can keep people alive. So next slide. All right, so I said a little bit of this, but what the law does at a glance: we decriminalize possession of small amounts of drugs. We did not legalize. That is a very important distinction, especially for policymakers and the public. And we absolutely are working through a lot of misinformation in our state and around the country around the difference between decriminalization versus full legalization. It invested over this biennium. Our state budget is in bienniums from 21-23 budget, $302 million. And we are just getting those dollars out the door right now, which is extremely exciting. And I was just doing a technical assistance workshop for our providers before this on now you got the money, what do you do now? How do we help you set up systems so that you can be successful in tracking and budgeting and HR and kind of all of the things that come with being a small community provider receiving a large state grant to expand services, because ultimately what Measure 110 is about is making sure that we're moving from a criminal justice response to a public health response. And in order to do that, we need our service providers to have the support that they need to be able to really do it. So we've expanded access to a lot of low barrier services. This goes through the different services that Measure 110 is funding, and a lot of these are non-Medicaid services. That was important to make sure that we're really investing in the services that are not generally funded, especially, you know, Oregon is last or 50th in the nation for access to services and second in addiction rates. So we are doing terribly on both sides and really wanting to make sure that, you know, we're not just building new systems, we're actually investing in the ones that are already on the ground that are doing incredible work, but just have not had the infrastructure or the resources to be able to really expand. And so that's the exciting piece of the different services that we are going to be working on. So it's housing, it's peer support, it's harm reduction and overdose prevention, and then low barrier treatment. So anything from detox, sobering, and outpatient. It also ensures that people who are accessing these services don't have to pay for these services. So Measure 110 covers all of the costs for these services. And we also, Measure 110 will also cover, you know, basically indigent care. So anybody who does not qualify for insurance, that's when Measure 110 would also cover residential. Next slide. So one of the things that, you know, because the funds have been so late to be released, which is a different conversation, we were able to, in 2021 legislative session, get $30 million invested early as we were setting up the program. Decriminalization went into effect February 1 of 2021. With just the 30 million, which is about 10% of the allocation, was invested, we know that 16,000 Oregonians were able to access services in 6 months. This is not tied to the citation that they received necessarily. This is not tied to anything other than we know when we invest in our communities, service providers, more people will be able to access services. And so instead of putting barriers or making sure that law enforcement was their ticket to get into services, our role is really about investing in those services. And since I'm in a new audience, I think it's probably helpful to just explain that the pathway, one of the pathways that was set up is that if you're caught with a small amount, personal use of drugs, which is detailed in the bill itself, but it also comes from kind of what our thresholds were as a state beforehand, and the measure just went off of that. You will, if a law enforcement pulls you over, stops you and you have a small possession, you will then receive a Class E violation, which is the same as a parking ticket, a speeding ticket, and that's a $100 fine. You can either call a hotline or go into one of our service providers to get a simple health needs assessment to kind of determine what kind of services do you need, if you need any, and are you ready and are you interested in getting connected to any of those services? Once you go through that assessment, the $100 fine is waived, the paperwork goes over to the courts, and it's taken care of. You can also pay the $100. We tried to really ensure that it doesn't become a punitive measure, so you don't end up racking up fines, you don't end up, ending up with a bench warrant for a Class E violation. So it's, some people say it's not enough of a stick. We feel like it's more important to ensure that people have access to services than, we know that we can't incarcerate ourselves out of this, this issue. All right, so next slide, please. So what did, those funds funded? Here's a couple examples from our local organizations. Bridges to Change is a really, is a large provider in our community. And they were able to open more housing and supportive beds. They were also able to keep one of their programs in rural Oregon open because they were about to have to close their house after, with all the different complications of COVID and everything else that had happened, they were getting ready to have to close down one of their houses. And this allowed them, this early infusion of funds allowed them to get the, to keep those doors open. And that's a facility that does interact a lot with kind of the court system to make sure that people have housing when they are transitioning out. Oregon Change Clinic, which was also received early funding, was able to get 28 housing beds for specifically African Americans and veterans, and also work for family reunification. Next slide. And we were able to open up a second recovery home for LGBTQ plus clients, and making sure that, folks are able to find that kind of safety as they are trying to get onto their pathway to recovery. We can't expect folks to be able to get into recovery without a safe place to go home, and without kind of those supports that folks need. And we know that this is an evidence-based practice for folks to have access to these types of things. Next slide. So peer services and outreach, I was actually just at the Miracles Club yesterday, doing a kind of legislative tour and local elected tour so folks could actually meet the peers and the outreach workers and really connect them to the work that they do. This is a long-standing recovery club and fellowship hall that has been in the African American community in Portland for a long time and is really well regarded and respected. They have been able to expand their peer support services and their outreach, doing incredible work out into the community, as well as obtain the home housing for African American women. And then Morrison Child and Family Services is expanding their Parents Anonymous. And I think and next slide is fine. As you all probably know, because the more of these types of services that really fill in the gaps and create the supports that people actually need as they are trying to either cut down on their substance use, stay safe in their substance use, or get into recovery, we need to have all of those supports, and they need to be culturally specific and they need to be linguistically specific. Measure 110 has done a really incredible job of making sure that we are investing in these small culturally specific providers, ensuring that we're building out our services for those folks and really expanding access. And then same with harm reduction and overdose prevention. As folks have talked about, it's really critical, especially as fentanyl is hitting our West Coast, that we are responding in a way where we really can meet people where they're at and get them the safe, health-based care that they need. So we were, across the state, we were investing large amounts of money into harm reduction services to make sure that folks had access to naloxone and safe syringe and wound care kits. Next slide. So for Measure 110, the first beginning of the law, it said that we were going to create like 11 to 13 addiction recovery centers across the state. What we recognized as we built the legislation is that that really wasn't what community and service providers needed. What it was is we decided to create these things called BERNs, which are Behavioral Health Resource Networks. And because this came from bureaucracy, we love a good acronym. And what this is meant to be is really a network within a county, and it's not based in, it's not kind of a county government structure top down to providers, but it is a relationship with the health authority and actually now 235 providers across the state that will be creating these networks. And the network has to have all of those services that I showed earlier. It has to have housing, peer support and recovery services, harm reduction services, and that low barrier health treatment services. So a network could be in Multnomah County, where Portland is. We have 41 organizations, and they have created 3 different BERNs. In Lane County, there's 3 BERNs as well. So it's really about a collaboration with service providers. They all had to create a memorandum of understanding with each other to ensure that they were, agreeing on how are they going to communicate, how are we going to do referrals, how are we going to work together. But the ultimate piece is when someone needs services, they're not having to do multiple intakes necessarily. It's really about making sure we acknowledge what they need and get them into whatever the services are that's within our network. This is just launching. This is a whole new system. And so there's going to be a lot of bumps along the way. And we're really trying to make sure that this works for the community. And we're creating something that helps break down a lot of the silos that we know really harm outcomes for individuals. Next slide. And so, for $302 million for Oregon, that's 5 times more than we've ever invested in these types of services. So there's a lot of hope for us in terms of really meeting community needs and really creating the services that are critical to make sure that we're meeting the needs of our communities. Next slide. And then this is a dashboard. I think it's, a really good dashboard for just understanding the landscape in Oregon. It's on the health authority's website, and it basically shows you how each county, how many organizations are in each network. And then if you get on it, I think the next slide, sorry, will show you how much each county was allocated in funds. And they weighted that by Medicaid population, houselessness, arrests, and drug overdose deaths. We know they're not perfect numbers because of the way that everybody, tracks these, but this felt really the way the council decided that this was really a good way to ensure that we were getting money to communities most impacted by the war on drugs and really focusing on folks who have been left out of the system for so long, and put a floor of, I think, $750,000 for some of the smallest counties that just wouldn't have even, with all of these allocations, wouldn't have made it. And I think the next slide shows the rest of our counties. We have 36 counties. Yeah, so you can see the $750,000. If you had taken the weighting, Wheeler County would have only received $90,000. And next slide. So this is for our communities, obviously, because it's in Oregon, but we wanted to just kind of give a visual explanation for folks on what a burn would look like. So we can just kind of walk through these quickly. If you go to the next slide. This is the complicated Multnomah County because it's 41 organizations, $58 million was allocated, and you can see just the amount of different types of providers and services that are on here that now all have, gotten about $58 million between all of them to provide and to meet folks where they're at and to do referrals and create a real recovery and harm reduction safety net in our county. And then I think if you just want to kind of click through them, you can see the difference between, Clackamas is our neighboring county for Multnomah, got 14 million, Washington County, so that's your tri-county area. And then I think we have a couple of our rural counties, Deschutes County, which is where Bend is for folks, and then some of our smaller folks. Everybody had to have, to create a burn, you had to have those services available one way or another. And some organizations stepped up and worked with neighboring counties to provide those services as well. I think that's, there's Lane County, so that's where Eugene is, and that's us. Hopefully that was a helpful kind of overview. There's a lot happening here. There's a lot of misinformation out there. And now that the money is finally out, which took about 10 months longer than was supposed to, we're really starting to see providers on the ground starting to hire, buy the housing that they are ready to set up, and recognizing that, there's been about 1,800 citations in 2021. So arrests are down about 6,000, I think was the latest report that I saw in last year for drug arrests. So that's 6,000 less people with barriers on their records for housing and employment and everything else that we know comes from that. And only about 91 people have accessed the hotline that was set up to kind of be that bridge until these providers were up and running. But I think it's really important, and as you all are kind of figuring out what Washington, which way you want to go, it's important to note that the citations weren't meant to be the only way people could access services, or we wouldn't be getting away from a law enforcement criminal justice response. It is a tool for law enforcement to be able to get people to services, but it's really not the thing that we are relying upon, which is good because there was 16,000 people that access services just because we created more services. So I don't know if there's time for questions and answers, but I'm happy to stick around.
Yeah, definitely time for about 11 minutes of Q&A. So if you've got questions for Tara, please go ahead and raise your hand. Yes, Representative Davis, go ahead.
Thanks so much for the presentation. My question is, within an individual burn, who is actually responsible for coordinating the care? Who is responsible for helping the person access the 40 octopus arms of the Multnomah County burn, for instance? And second question to that, is there any element of the $302 million being invested in outreach? So proactively trying to engage with individuals in active addiction, whether that's in encampments or emergency departments or correctional facilities?
Yes, both great questions. So I think one of the things that we were trying to do with burns, and again, this is going to be a process, is that each, as is really similar to Washington. Each community, each county has very different needs and different providers who, have different levels of relationship. So for Multnomah County, the 41 octopus arms are actually now have created 3 different burns. One is a very kind of culturally specific providers that have been meeting together and trying to figure out kind of how they want to operate and how they can coordinate with each other. There's not one central hub. So and there is a lot of outreach, funding for outreach and prevention. So just as an example, Miracles Club, which I was talking about earlier, they're part of this burn in Multnomah County called Indigeneity. This is the culturally specific burn. And they have outreach workers. One of them I was talking to yesterday. They go out into encampments. They go find folks that may or may not, that are looking for services or are open to talking. And depending on what that person needs, it's really, these burns are meeting with each other, sometimes weekly, to kind of go over who's got what and how they're able to connect folks. So if I'm an outreach worker going out to an encampment and there's somebody who identifies as LGBTQ plus, then and I need and they need housing, I'm going to go over to Quest and say, do you have any housing available for this person? And then that's kind of it's that informal collaboration that a lot of our providers are already doing, but with a little bit more structure, because there's money and MOUs done with each other. So and then, you know, you look at a small county like Sherman County, and I think it's only 2 providers. That's a very different relationship and a very different kind of referral base. But each memorandum of understanding, in order to get your money, you had to show, how are we going to do our referrals? How are we going to communicate with each other? And how are we reporting out as a burn back to the Oregon Health Authority? So trying to keep it as flexible as possible, recognizing it's also public funds and making sure that we're holding folks accountable as well. And really prioritizing that collaborative relationship between providers so that they can be, you know, it's about trust and relationships. So if I'm at Miracles and I know Quest and I know that they do a good job with their housing and I can trust sending somebody over there, that is going to be my path. And recognizing that we're now opening up more housing spaces, more beds, the referral process will be, ideally will be much easier. So I hope that answered that. But a lot of our folks definitely applied and received funds for outreach to make sure, you know, in Eugene, we have a group who was just able to buy their own space. They've been operating out of tents in parks, serving young adults in the houseless population. And now they've just been able to get their own space so that they can actually host those folks in a safe space to do all sorts of skill building, peer support, resume building, kind of the whole thing, and create this really dynamic center. So it depends on the people, depends on the needs of the organizations.
Great, thank you. I don't see any hands up, but I do see questions in the chat, so I'm going to go ahead and relay those to you. Lisa Dugard asked, is anyone studying the racial disparity impacts post-implementation?
Yes. The Criminal Justice Commission did an initial study before Measure 110 and recognized that the racial disparity, the racial impacts would go down 98% if we were able to implement Measure 110. I know that there's some initial studies happening right now looking at and kind of parsing out the data of who has been arrested or cited and what are the kind of racial breakdowns of that. There's definitely some challenges with that data because it's identified by law enforcement when they do the stop, but we have seen a significant reduction in the targeting of communities of color, at least because you can't stop people for small possession.
Thank you so much. There's a couple more questions in the chat for after this if you have time, but I do want to call on Chad, and Ray just got his hand up. So Chad, go ahead.
Thanks. I just had a quick question, and I guess it's statistics, because you had mentioned that there's a lot of misinformation out there, and I'm trying to figure out the overdose rates for Oregon compared to the rest of the country. It looks like it's it really spiked in 2021 and is significantly higher than the rest of the country. Is that accurate? And if it is, what's been the response to that?
So I think it's, like a lot of things, we are still trying to, especially researchers and data analysts, and I am neither, so I'm just going to say that right now, are trying to pull COVID, what is the pandemic, and then in isolation and, just kind of our lockdowns, what is that impact versus any new laws that you can overlay. When we've done some of the more simple math, when you look at the full West Coast, Oregon's influx of overdose deaths is consistent, if not a little bit lower than the West Coast average. I think that, we are 50th in access to services and second in addiction rates. So our overdose death rates are going to ultimately be higher. And Measure 110 the money didn't really, that first infusion that I told you guys about, the 30 million that came out in July of 2021, and 60% of those funds were used for harm reduction services. That's how people utilize those funds and utilize those services. So I think that it's, some of the data that we're going to need to do more digging on as we are able to really pull apart what's a global pandemic outcome versus just a potentially decriminalization is looking at how many people were able to access those services. I know that just from, talking to providers, one provider was able to reverse 500 overdoses because of those 110 funds. So there was a lot of I think we probably would have had more overdose deaths if we hadn't had those funds go into our harm reduction services across the state. So there's a couple studies that are being done right now. One of them, I think, for the CDC that will be out, or at least be conducted through October, November, to look at the impact. If you can say that 110 has had an impact on overdose deaths, what is that? Or is this more of a national trend that we're seeing, especially with fentanyl coming over to the West Coast?
Brandy, go ahead.
Sorry, no, I messed up on chat, so I'm sure you didn't understand my question in chat, Tara. So my question is, I know that you said like you're not picking people up, but what we're finding in Seattle that now our prosecutors are filing charges for folks from things that happened in 2020, and they're now filing those drug charges. And or do you guys do any kind of data split that looks at folks that it might not be drug charges they're getting picked up, but we're seeing people picked up on property damage, trespassing, things of that are, to me, are related to drug user activity? Are you seeing any increase in that in terms of law enforcement?
So it's a good question.
Or theft's a big one too.
Yeah.
They're really getting our drug users in theft.
We haven't been seeing an increase necessarily in kind of what some people have been concerned about and that we need to continue to keep an eye on is, are they shifting from like being able to arrest for one thing and shifting it over to another? And I think that will take longer for us to really be able to parse that out. But it's not from an anecdotal space of like talking to folks, on the front lines of this. That's not necessarily what we're hearing. And it depends. There's Josephine County which is a very small county in Southern Oregon, or like small population. They've done the most citations out of most of our counties, especially per capita. And I think that, everybody is looking at these tools differently. I think for Josephine County, they feel like this is the best way that they connect folks with services. And in Multnomah County, which may be, which is more similar to King, it's like the voters were clear. You don't want us kind of responding to small drug crimes, so we're just going to move on to other issues. And that seems to be parsing out when you look at the kind of initial data.
Well, if you guys do get a chance to look at that, I'd be interested in knowing racial disparity wise what that looks like, because I see more of our Black men being caught up on this shift since they can't get them the other way.
Yeah, we're waiting for that first FBI kind of drop of data, I guess, comes out in the end of September, and the Criminal Justice Commission will be looking at all of the different increases and or decreases of arrests, crime, and then breaking that down through racial data.
Thank you so much, Tara. We are at time for that, as well as the presentation portion of the meeting in general. So thank you to all our presenters today and for answering the questions. I know that there were questions in the chat that we didn't get to cover verbally. So if you want to check those out to see if there's other questions you can answer via chat, that would be fantastic. And we'll move in now to the next portion of the meeting, which is revisiting the top polled options from the August SURSAC meeting and building those up now with any additional comments or ideas or concerns that have come up during the meeting from today. And the goal really is to have 2 to 3 really solid options for the SURSAC to vote on Monday. And I'll go ahead and pull up that document. We've got previous comments from the last meeting and then another column for new comments for this meeting. So we can make sure that we're capturing all of that. And as much as possible, if you can help me distinguish between the things that are policy-specific criminal legal response versus the things that you want to discuss in general that, for any kind of policy that would still apply, that will help us really narrow down what we're talking about in terms of the possession response. So I'll go ahead and pull that up now. Blake, are you on? And
I am here.
Okay.
Yes.
Okay,
Thank
great.
you, Michelle.
So yeah, hand it over to Blake to facilitate as I take notes now.
Sure, you bet.
Michelle, this is Michael. I just would like to thank the speakers as well.
Yeah.
It has been a lot of content in a really, 2.5 hours here or something this morning. Thank you all for coming on, for sharing what you've shared, for answering questions. Clearly, there are more questions than we have time for, but really appreciate you coming on. And hopefully this gives Michelle a minute to breathe between discussion items as well. So thank you. And for members, please give us your input at this point as we prepare for Monday. And Blake, take it away. Thank you.
All right. Thank you. Thank you. Yes. Fantastic presentations. Thank you so much for your time and effort with those. So as Michelle was saying, we are looking, we've gone through this list before. If you remember, this is the one we talked about, I think, the last regular meeting, and had discussions about, you can see the highlighted there, and then underneath that we have, kind of the discussion that we had around that. So we want to get more comments from you based on what we heard today. Relative to these things we voted on as far as responses to possession in the last meeting. So in the first one, we had maintain possession of controlled substance as a misdemeanor with diversion options, and we had 12 yes votes on this one. Is there anything you heard today, given the presentations, that you'd like to comment on? Maybe you have more ideas on this, or thoughts, pros, cons, anything that you want to add to our discussion on this particular response to possession for our efforts on Monday for a vote? Anything you want to add? Or any general comments? Yeah, Chad, go ahead.
Yeah, I would just say that, and I've shared this before, possession as a misdemeanor is practically unworkable. As a prosecutor, we have to prove what the substance is. That requires us to send it to the crime lab. The crime lab will take over a year on a misdemeanor. A misdemeanor does nothing. I think that It is effectively decriminalization. And so I think if we want to say decriminalization, then let's say it. The misdemeanor is just, I think that's just cover for something that's really going to be unenforceable.
All right, thank you, Chad. And Caleb had a comment there in the as well in the chat. If you want to grab that, misdemeanor still criminalizes substance use. It seems predicated on the idea that it's helpful way into services. But if we have other better ways to better services, it is not needed. Thank you. Any other comments? And again, it could be, you know, anything on your mind here from today, or just things you want to throw out there for consideration by others.
What constitutes possession? Like, how much is too much of different substances? So,
great question. I'll let somebody else take that one.
Yeah, when this was talked about the last meeting, we didn't get into amounts at that point. So I think we heard maybe from Mark at the beginning how complicated this work can get. And once we get sort of that general high level, you know, should it maintain as a misdemeanor or not, we'd have to look at what's on the books now and any proposals to change that in terms of amount. So I don't know that we have that detail for you today, Cody.
Gotcha. Thank you, Michael. Okay, anything else on the first option here, or on the option that we labeled number 1 anyway? Okay. All right, let's go to what we labeled number 2. We had 9 people vote on this, and this was decriminalize possession of a controlled substance and paraphernalia with no civil penalty or fines. Anything that we heard today that, or other thoughts that you've had from our previous work that you want to add? Julian.
Yes, I would like to add that harm reduction should be in all the options. I think it's kind of a separate issue. So I want to make sure it's not, I guess, should be included in this one as well.
Okay. Thank you, Julian. Appreciate that. Okay. Okay, nothing else on that one. Again, just trying to get your comments from what we heard today to add any kind of context to this. Number 3. Oh, sorry, Senator Ingra. My apologies. Go ahead.
No worries. I raised it last minute because I was just trying to make sense of the last bullet point where it says we have an overdose death rate that rose at twice the national average. And it almost sounds like that is put there because that's a correlation to the decrim. And I don't know if that bullet point is actually saying that that is correlated to that recommendation. I'm sure there are a lot of other causations for the overdose death rate. So anyway, I just thought I would, I just was confused about that in terms of number 2. Because I don't believe that data point changes any of the other recommendations, right? Unless we're trying to make a causation argument there.
All right, thank you. Appreciate that. All right, and Sarah.
Yeah, for number 2, I'm wondering, I've heard a lot of people mention, and it sounds like, right, we are in sort of a state of de facto decriminalization. And so I, not being a policy expert myself, would just be curious what folks might think would look different in practice if we were to move to, decriminalization in writing and law versus sort of the de facto decriminalization state that we're in currently.
Anybody want to comment on that?
You know what? I'll just say many times it's just political. The first version of the bill was trying to emulate what we're seeing in the community, and that frankly didn't pass. So I think this is why this committee is important, and I wish more legislators were part of it so they can understand truly what's happening at the real level, but they don't. So I think this is where politics comes into play, frankly, and just this lack of really understanding what's happening on the ground.
Thank you. Julian, you have another comment?
Yes, I would add that, without legislation that says it's non-criminal, people are not, like, people don't even know that it's quote the status quo. People don't know, we don't have services available at this point. We're not educating people or reducing stigma. So it's not, you can't quantify that until everyone says, yes, this is what we're doing. And everyone understands that it's a health issue and not a criminal issue.
All right, thank you, Julian. Kurt? Kurt, can you hear me?
Yes.
Maybe
finally.
Okay, great. Yeah, you bet.
And I struggle with SUD is a health issue as well, because it is a health issue as a symptom, but the cause is a societal issue that where substances become a method of coping. More than anything else. So I think that where we stand is because of our change in society, and no one really talks about that.
All right, thank you. Okay, I don't see any other hands up. Yeah,
Blake,
go ahead, Michael. Yeah.
Yeah, I'm keep looking at the point that Senator Dingren and Caleb commented on about the status quo. And if I think back, I think what that was meant is it was kind of a comment about we need to do something more one way or the other. That while we are where we are right now, our overdose rate is really high. It probably, like we said in here, it doesn't have a whole lot to do with where we are with the penalty, but we should do something more, either be more lenient or more strict, one way or the other in order to maybe address this. I think that's where that came out. I recall the discussion at the last meeting. It was like, but if we settle here, we're sort of settling where we are, and we have a big old problem where we are right now. And we'll have to talk about that more on Monday, but I think that's where it was from. Just wanted to put that out there.
All right, thank you. Malika.
The context of that statement was trying to draw a correlation between what has happened with 5476 and the increase in overdoses. But to Caleb's point and to what is the general knowledge around this, it is the late arrival of fentanyl in our drug supply is what has created this upward trend. We're not even at the spike yet. We're just on one side of it. So, and it's the exact same trend that we've seen nationally. So the feeling as a SURSAC member that was a part of that conversation, it felt very much to me like there was a correlation that was trying to be drawn between the two, and it feels very prejudicial to have it as a bullet point underneath this. At the time, I voiced concern about it, and so I'm going to add my voice to Senator Dingren's. That is concerning to me that it seems prejudicial to have it under this bullet point.
Are you suggesting that I remove the comment that was made by another SURSAC member?
What I'm suggesting is that I don't know that it is being related as it's related to this particular suggestion, and it's not. It was a comment. Of course it needs to be memorialized in the notes. I'm just not sure that it needs to be I question whether or not it should be associated with the the proposal.
So,
I mean,
I was just,
HCA will do what they want to. I mean, that's what y'all do. But I'm just saying that it seems prejudicial.
so if I can just jump in here, I think it is challenging to remove a comment that another member has made, but I think that explanation regarding causes for overdose death, I think that helps. And I think being careful about assigning causation is also helpful. But I also don't want to be in a position where we're censoring other members who may have a minority position. So I think being sensitive to that is important, but I think the explanation is very helpful. Thank you.
And maybe including the explanation as it was mentioned the first time around too, as a bullet point would be helpful too.
Okay.
Yep. So we want to add comment there.
Yeah, I'm not, I'm going to need a little bit of help at knowing what exactly to add.
Yeah, Malika, what can you help us out with the verbiage there, if you don't mind again?
Caleb
Sorry
already
about
put
that.
it in the chat.
Oh.
So, I mean,
Okay.
it could
All
be
right.
cut and
All right.
pasted
Thanks.
from the chat.
I'll pull it
Thank
from
you.
the chat. Thank you.
Okay, Michael, did you have a comment? Looks like you.
No, just
Okay.
wanted to make sure we're having the conversation. So thank you.
Yep. Okay. Let's go ahead and move on to what we have labeled. Well, let's let Michelle do that first. Sorry. All right. Thank you. Appreciate that. If nothing else on what we labeled 2, let's go on to number 3. What we have labeled number 3 anyway. Okay. Decriminalization, decriminalize possession of controlled substances and paraphernalia and make it a civil penalty punishable by fine, community service, and or waived with completion of health assessment. We have 8 yes votes for this last time we did this. Any comments about this?
This sounds a little bit like what Tara was mentioning Oregon's doing with the $100 piece. I kind of picked up on that.
Mm-hmm. Anybody else have other things they want to add for context for our vote on Monday? Yeah, Hunter.
Yeah, so I about this. I think this could depend on what the fine would be, but I do think that this could be problematic for someone who isn't financially comfortable or has struggles with their schedule. Maybe they have a job and a rough family situation as well that could already make it hard to work. So then community service could be a problem. But I think those would depend on what the fine or community service would entail.
All right, thank you. Okay. Just reading comments. About in Washington, unlike Oregon, citations become grounds for criminal filing if not responded to. That means that it is not effective decriminalization.
And Brandy,
Yeah,
go
and
ahead.
so the same. Yeah, go ahead.
So Brandy, go
Hey,
ahead.
Brandy. Yeah, Brandy, did you hear us? Okay.
No, I didn't
Sorry.
hear anything.
Sorry about that.
I'm wondering for 3, can we take the fine off altogether? Like, we have the power to take fine off altogether. We're trying to do something different where drug use is a health issue. And so you are just penalizing me for struggling with my health issue, right? For struggling with that. I don't know why we can't take fine off altogether. Why are we continuing to the regular status quo?
Right. And Brandy, that's the option up here.
Yeah.
The number 2. So decriminalization with no penalty for no fines, no penalties, and in decriminaling paraphernalia as well. So if that's the one you support, then that'll be an option for Monday.
Well, I guess I'm just saying, why even have 3 as anything? Even though there's another option, if we're all here to do something completely different, we're putting this other status quo option on there. It shouldn't even be an option, so we don't create bad policy, period.
Well, there were 8 members that voted for it at the last meeting. That's why it's there.
True. Let me stop because I'm going to get upset. Like, just because the majority of you like it doesn't mean that it's a good thing, that it's not bad policy, that you're not thinking about the racial equity components that's going to come to this as well. We're not even considering that, but that's my comment. I'll be quiet.
Thank you for the comment, Brandy. All right, Everett, you had your hand raised.
Yeah, I was just gonna, take us back a step on this question of how are we, are we associating a rise in overdose death to recent lawmaking or to what? And I just want to kind of say I've seen over a period of months now that Malika is kind of out presenting racial equity and justice to this group, and she's facing a lot of probably unintentional microaggressions from some other people in the group when she speaks up, and I just find that very troubling. And I know everyone has the best intentions here, and these are really hard conversations to have in general, but I appreciate the work that Malika has done to try and maintain a focus on racial equity and justice here. So thank you for that.
Thank you. Okay, anything else on what we've labeled 3? All right, let's I thought we were going to do supply. We could do, well, let's do safe supply initiative then next. I think that a great deal wanted this today as far as discussion. And Everett, is your hand still up? All right, Caleb, did you want to jump in on this one or the last one?
Well, I have a question. The one SURSAC meeting I missed was this one, so I'm a little unclear on the framing. Safe supply initiative doesn't seem like a separate piece. It seems like a component piece.
Michael,
so it's not an alternative. So is that correct? It's just so it seems like the committee is voting on a recommendation. As my understanding from my wonderful student Adam, safe supply is an essential component of legalization. It doesn't work otherwise. So I'm not quite sure on the framing of this as a separate option.
Yeah, Blake, do you want me to take that?
Yes,
yeah.
Please.
Caleb, I agree with you. I think we agree with you. We were preparing for this meeting. We did vote on it as a concept. There was a lot of support for it, and so it's left on here, but it isn't the direct response to the question. So I think we wanted to leave it on just to make sure people understood that we heard you. And then whichever options we end up going with, we'll have to determine whether we want that to be part of this or not. But that's why it's still on there. The next option, real option in terms of the response is, I think, number 5 there. But
so with that, if it's okay, let's actually go to Kurt. Kurt, go ahead.
With regards to the safe supply, I would just like to see something in there, as long as that is not shown to increase substance use or increase crime, burglaries, whatever else, and still, in order to purchase, whether it's a safe supply or off the street, those substances. I just don't want the substance issue to be promoted through safe supply, and I just haven't seen any information regarding that.
Thank you. All right, Lisa?
Thanks. My comment is actually about the last one, and I can hold it.
Okay.
I put it in the chat. So up to you.
All right, we'll grab it out of the chat. Thank you. Come
Yep,
back
you
to you
bet.
if we. All right, Malika.
So there actually is a lot of research about decriminalization, and also there's emerging research, emerging information coming out of Canada. So in places where decriminalization, for example, has happened, increase in substance use actually goes down across the board, including with legal substances such as alcohol. That's something that Portugal taught us many years ago and continues to teach us with their decriminalization approach. And just because a substance is legal doesn't mean that everybody's going to start using it. I mean, you know, alcohol is legal. I don't drink on a regular basis. Just marijuana is legal. That doesn't mean that people use it all the time. I think that, we have this misinformation, and also what comes around with having a safe supply and like moving towards decriminalization and potentially, hopefully, some legalization, is that research becomes easier to do. One of the things that we just saw with the Students for Sensible Drug Policy, they were successful in countering the scheduling of a psychedelic substance. I can't remember the exact name off the top of my head right now, but so that it can, and it's something that's used quite frequently in research to address trauma and to evaluate how psychedelics are improving people's outcomes with behavioral health issues. And part of the reason why it can be used so freely is because it is very similar to the substance, the active substance that's in psilocybin, but psilocybin and these other forms of psychedelics are illegal, but this particular form is not. So, like, we need to increase our understanding around what it actually means rather than responding out of fear, but understanding that, a decriminalization framework, a safe supply framework, doesn't mean that it's going to be a whole entire free-for-all, lawless free-for-all. What it means is that we're going to be able to target access to the individuals that need it. And just because something is available in a safe supply doesn't mean that everybody's going to start using it. Like, if something is available in a safe supply, does that mean that you would use that? I mean, I think these are things that we all need to think about. And to assume that people that use drugs, which I would say is all of us, how many people drank coffee this morning? But I mean, it doesn't mean that people are self-determined. They're able to make decisions about what they're going to do and what they're not going to do.
Thank you. Okay, Hunter, and then Paul. Hunter?
Yeah, all right. Oh yeah, sorry. So see, there was a thought that crossed my head during Adam's presentation, which I think is relevant to what we're talking about with safe supply here. And that was with the concept of that people who don't have SUD or don't use drugs will start using drugs. And I was thinking about how sometimes when we talk about relapse, that relapse often happens before anyone has taken drugs, and that it's when they're in like a contemplative stage that they might use again. And I kind of relate that to when someone is interested in experimenting, that once someone has started to consider that they're going to use a drug, they're very likely going to use it. So I still think that the safe supply could be helpful to those people. And also thank you, Malika, for some of the points that you just made. I don't have to explain as much now. And I agree with everything that you just said. So yeah, thank you.
Thank you, Hunter. Paul?
I think it's very important that we don't equate drug use with problems from drug use. The issue is health problems that people have as a consequence of drug use, up to and including overdose and death, and the other various social complications that might occur with somebody who has problematic use. Many people use drugs without having a problem from those drugs, unless society makes it a problem for them. And so the issue with a safe supply is not whether or not it increases use. It is important to make sure that it doesn't increase problems with use, but I think it's essential that we make a distinction between those concepts.
All right, thank you.
Also, on this topic of safe supply, under the bullet points, I think something more has to be said than just the goal is that because people are not going to stop using, we need to recognize that and supply them with safe drugs. I mean, this is also a way to engage people in a system that might help them instead of them having to go outside the system to get the drugs that they feel they need.
All right, thank you so much. Rep Davis?
Thank you. I just, I'm sort of a broken record on this, but when we do talk about full legalization, it is true that it can run a gamut. It is also true that we have not legalized an addictive substance where it has not taken on the addiction for profit model, cannabis being the most recent example. The failures of recreational cannabis are so profound that we're having an entire summit that ADAI is putting on the 16th of September, talking about the public health impacts of the high potency cannabis that was created through the commercial market and has created a range of problems that were virtually non-existent in the prior to legalization, including cannabis-induced psychotic disorder, cannabinoid hyperemesis syndrome, and significant cannabis use disorder. So sure, you could do it theoretically, but I've never seen an example where it didn't lead to addiction for profit. So I very much oppose the concept of legalizing other drugs.
Okay, thank you. Appreciate your comments. All right, so on the last here, legalized possession of all controlled substances, create a regulated market here. We just had one comment on that from Rep Davis. Other comments on this before we get to a quick, if we can, Michael, quick public comment section here. So, okay, Paul, did you still have your hand up? Let's go to Amber.
Yeah, I just, after hearing Adam's presentation, I wanted to, maybe specify in the notes for that safe supply option that there are multiple different frameworks that safe supply option can go under.
Okay.
So, maybe just letting the SURSAC committee know that might be helpful in making a decision.
All right, thank you. Lisa, did you have comments on what we labeled 5? You're on mute.
Sorry, yes, I am. Yes, I do. I recognize that we're not going to legalize all drugs in Washington in the next legislative session. However, I really do hope that we pick up sort of the threads that are emerging to build a consensus that we have to do more than just decriminalize possession, both in order to effectively reduce crime associated with procuring drugs on the illicit market, which is a huge factor in the feeling that this is an emergency. Overdose deaths and ancillary crime are the two felt impacts, and an approach that addresses both is the best way to build the broadest support for a public policy framework that can be stable and that we can invest in. And if we just decriminalize or de facto decriminalize possession, but do nothing about the distribution process, you guarantee continuation of all those ancillary crimes, which has a way of delegitimizing a health-based response to this problem. As well, with great confidence, I predict that approach will exacerbate racial disparity among those who are left to the criminal legal system. Having a legalized product, the production of which occurs and distribution of which occurs under conditions of under punitive and unsafe conditions is the type of thing that when we're talking about diamonds, iPhones, and other commodities, we recognize how incredibly unethical that is. And the same is true of drugs. These are widely consumed goods. And if you leave the people who produce and make their living in, including at a subsistence level and getting them to people, and then the people who get them, including very affluent people, face no consequences, to me, that's the definition of an unethical system. And the racial disparity of the war on drugs is hyper concentrated in enforcement around sales, and less so, not that it's not there, but less so with respect to possession. So I just hope that we can recognize those factors, and whatever recommendation for immediate policy change comes from SURSAC or direction, might not be change, that we have some agreement that we will work on these issues in the name of reducing racial inequity and in the name of reducing ancillary crime. There's no one I have more respect for than Representative Davis. I'm hearing loud and clear, like the commercialization associated with existing models of legalization is very problematic. I'm sure that's true, but maybe we could go about this in a new way that attacks all of these critical issues.
All right, thank you. So Amber, we have almost out of time here. If you have a real quick statement, and then we'll move on to public comment here real quick.
Yeah, just real quick, I was kind of misquoted.
Oh,
when
sorry
it
about
talks
that.
to being implemented in conjunction with a range of criminal legal response options, I was talking about the frameworks for a safe supply option that Adam was talking about. And I think it's important to put the three common features in also, that licenses coupled with education would be part of this. There would be labeling on packaging and signing of a waiver, and the education and use, as well as packaged with harm reduction supplies. That's really important. We talked about the different frameworks, the dispensary-based model, the community-based buyers club, prescription and take home, supervised, prescribed. There's different frameworks that can look like, is what I was getting at.
Sorry about that. Thank you for the clarification.
All right, I've been informed that others have meetings at noon. Does anybody from the public have a comment? We've got 2 minutes left.
Blake, I don't want to shut anybody out. However, we have taken member and non-member comments throughout, so it feels like maybe we've captured.
We're there. Okay. Okay, and we also have the meeting on Monday as well. So I'll turn it back to Michelle, you and Michael, and to take us out.
Sure. So just to wrap things up, I'll be sending out this updated document with your comments from today with the top polled options. So we do have four options that we'll be putting out for a vote on Monday. There's the maintaining possession as a misdemeanor that had the 12 votes from before and additional comments. Decrim with no civil penalty or fines. Decrim with as a civil penalty. Safe supply initiative, we've agreed that that's not its own policy. That's something to consider in addition to the criminal legal response. And the number 4 option would be legalized possession. So those are the 4 options that we'll be voting on Monday, and you'll have these notes as well as the notes from today's meeting to use. I hope to have the recording available for anyone who missed the meeting today up this afternoon. I realize it's a tight time frame before Monday's meeting, but doing what we can. So that is the plan. Michael, any final comments?
No, thank you. Michelle, Blake, all of the presenters, really appreciate the planning that went into today, the ask for the extra time by members, And I think we learned a lot today. So thank you all for coming forward. Senator Dinger, I'm not sure if you're still on. If you wanted to say a word in closing, I think we can close up. She may have had a drop off. So with that, thank you all. And for many of you, we'll see you on Monday. Appreciate your contributions today.
Thank you, everyone.